اللي يبدأ من هناك الشباب هناك. يلا. Okay, ready? يلا.
Recording in progress.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. Good morning, ladies and gentlemen, dear colleagues. It's my pleasure again to start the second and the final day of the ASCO review. I hope you had a good night and a good dinner last night. Thank you for being with us. It gives me more pleasure actually to introduce our next speaker. Our next speaker is Dr. Fahad Bin Shamsa. Dr. Bin Shamsa is the chairman of Medical Oncology Department and Senior Consultant Medical Oncology at King Fahad Specialist Hospital in Dammam. He's very well known to everybody, and he's a figure in the field of GU cancers as well as GIT cancers. And he is going to present the abstract of the Everest trial. Dr. Bin Shamsa, please, the floor is yours.
Thank you very much, Dr. Isam, and thanks to the organizing committee, Dr. Amirvat, and her team, inviting me to have the privilege to be with you today and to talk to you about this abstract that was presented in the last and most recent ASCO a couple of weeks ago. So the SWOG trial, Everest, everolimus for renal cell carcinoma, ensuring surgical therapy. It's a phase 3 study, adjuvant everolimus. And as you know, almost 1/3 of RCC patients develop recurrence after a nephrectomy. And yet, to this point, the standard of care is surveillance, despite the recent keynote study. And a new generation of adjuvant studies since 2006, several studies, SURE, SOURCE, PROTECT, ATLAS, and ISTRAC study. So most of them were negative, with the exception of the ISTRAC study, which showed some PFS benefit in the subgroup, and also the most recent keynote 564, which showed progression-free survival benefit, but yet none of them show overall survival benefit. So mTOR, as you know, coordinates cell growth and proliferation, and everolimus was approved in 2009 as a second-line treatment for renal cell carcinoma post-SUTENT treatment. So here's the study design. So patients who had resected renal cell carcinoma, they will be randomized within 3 months, 1:1 ratio to either everolimus 10 milligram once daily for 1 year, or placebo for the same duration of treatment. These patients had nephrectomy, either partial or radical, and their TNM stages ranges from T1B with the grade 3 or 4, or any T2 or above, or any node positive disease. These patients are either clear cell or non-clear cell carcinoma. So this is one of those studies that included non-clear cell carcinoma. Of course, patient has good performance status and had no metastasis. Patients were stratified according to their risk group, either intermediate high versus high risk, also according to their histology, clear and non-clear, and of course performance status. The primary endpoint of the study was recurrence-free survival, which is the usual endpoint for adjuvant studies. Secondary endpoints were overall survival, toxicity, and other efficacy points. Here is the risk stratification of this study. So they are either intermediate high risk, who are T1B with high grade, or T1 with any grade, or very high risk, which is T3 A and above, or with high grade, or T3B with any grade. So we learned from the STRAC trial before that those patients who benefit from adjuvant statins are the one with high T3 and above. So that was the lesson we learned, and that's why it's affecting the adjuvant studies, the Everest, and also the keynote studies to stratify patients according to their risk group. So the planned sample size was 1,170 patients, but due to early treatment discontinuation, they calculate a newer and bigger sample size of 1,464 patients. So they conducted the final analysis with 556 recurrence-free survival events in March 2022, and they presented in the ASCO 22. So 1,545 patients were randomized from 2011 to 2016, 775 for everolimus and 770 for placebo. The treatment discontinuation was 55% in the everolimus group, 37% because of adverse events, which is relatively high rate of discontinuation, 8% due to disease recurrence, and 10% for other reasons. These are the patient characteristics, and it's a very well balanced study. But I'll take your attention to the risk group, which is very important, and you will see later that it's probably the most important part. Very high risk, where 55% in both groups, intermediate high risk, 45% in both groups. So you would expect from these adjuvant studies, the STRAC, Everest, and also in the keynote studies, that it's always patients with the higher risk. They are the one to benefit from adjuvant treatment. Median time on treatment was 9.3 months for everolimus, 37% dose reductions, and 47% discontinuation due to mostly adverse events. Here is the most frequent adverse events for everolimus, and you can see any grade was 96%. Grade 3 and above was 46%. Mucositis was one of the most common side effects, 64% in any patients. Grade 3 or above, 14%, which is expected from everolimus. Pneumonitis, which is also a side effect of interest that we all worry about when we treat with everolimus. Any grade was 13%. But the grade 3 and above was only recorded and reported in 1% of patients. For the laboratory abnormalities, hypertriglyceridemia, 53% in all grades, 11% was grade 3 and above. Also, hyperglycemia was 35% of any grade. Here is the primary endpoint of the study. So recurrence-free survival was improved with adjuvant everolimus compared to placebo to 67% 5-year recurrence-free survival compared to 63% for placebo, so an absolute benefit of 4%. This resulted in hazard ratio of 0.85 and p-value of 0.025. Despite that, this p-value did not cross the pre-specified boundary of statistical significance of 0.022. So you'd like to look at the subgroups and identify who are the subgroups that would benefit most from adjuvant everolimus. And surprisingly, it was African American. They showed that they do benefit more than others. And also, as expected, the very high risk, which is a good number, 819 patients, they really do benefit markedly compared to the intermediate high risk, which is expected. So this is the efficacy by risk group. If you go for the very high risk, so the 5-year recurrence-free survival is 57% compared to 51% only for placebo. You see the curves on the left hand very clearly separated. Hazard ratio now improved to 0.79 and p-value improved to 0.011, while in the intermediate high risk, you see the two Kaplan-Meier recurrence-free survival curves are superimposed and identical. There is no separation, and this group of patients does not derive any benefit from adjuvant everolimus. When it comes to overall survival, there was no difference. 87% 5-year overall survival for everolimus, 85% for placebo. So in conclusion, adjuvant everolimus improved recurrence-free survival in renal cell carcinoma patients after nephrectomy, but nominal significance level was not reached. So basically, when it comes to primary endpoint, it's a negative study. So the effect, when it comes to subgroups, the effect of everolimus in improving recurrence-free survival was mostly and pronounced in the very high risk disease. Adverse event, it's were what we expected, but it was noted in the study a high rate of treatment discontinuation in everolimus population. So these results really warrants further investigation into the adjuvant role of everolimus and subsets that may benefit most. I think if we are to design future adjuvant trials in RCC, we need to include high risk and only the very high risk patients to show the benefit. We learned this lesson from the EVER study and previously from the Keynote and ESTRAC study. Thank you very much.
Thank you very much, Fahad. We'll hold the discussion until the end of the session. Elegant presentation as usual. Sorry for not introducing the chairpersons. We were in a hurry to start. I'd like to introduce the chairpersons, Dr. Omar Al-Tayyib. Omar is a medical oncologist consultant at Tabuk Military Hospital, King Salman Military Hospital in Tabuk. And Dr. Iman Bukhari, she is consultant palliative care and head division of palliative care at PSMMC. Dr. Faris Al-Hussein, Mohammed Faris Al-Husseini is senior consultant medical oncologist and also the head of medical oncology at Al-Hada Military Hospital. And now with Dr. Omar.
Thank you for Dr. Murshid for this presentation.
Thank you, Dr. Isam, and thank you for all team for the organization of this event and to invite us to be with you in person in Riyadh. We are happy. Thank you very much. Now we will move to the second topic with our colleague and friends, Dr. Ahmed Al-Rifai, who is online with us, and to present the phase 3 study Keynote 564 study. Dr. Ahmed, please.
Thank you so much. I would like to thank the organizing committee, Dr. Isam Murshid, Dr. Mirvat Mahrouz, and I would like to thank you, Mr. Chairman. Today I will present the Keynote 564, and actually they were very active. They just made like 3 updates for this trial. So I will start to speak about some facts Actually, kidney cancer is increasing in incidence with about 430,000 new cases per year worldwide and 175 to 180 deaths worldwide. And we know that the nephrectomy is the standard treatment for the local regional disease. However, nearly half of the patient eventually will experience disease recurrence. So we are in desperate need for some sort of adjuvant treatment. We heard Dr. Fahad Bin Shamsa now just he introduced the Everest and it came as a negative trial. And we had before 5 trials using adjuvant TKI. 4 of them were negative. Only the ASTRAC trial just showed positive result in the form of improved in the disease-free survival, but no improvement in the overall survival. And toxicity was high. I mean, grade 3 was 48% and grade 4 was 12%. So 60% grade 3 and 4 toxicity discontinuation rate was 28% was Sutent. And this is why, I mean, many of us, we are not using the sunitinib in the adjuvant treatment. Maybe this is the time for the immunotherapy. In the last 7 years, 7 immune checkpoint inhibitor was approved in 90 indications. And we can see that 12 approval in non-metastatic setting, I mean, no gross disease, only microscopic cells there. And 8 of these approvals were in the adjuvant indication. So maybe this is also the time for adjuvant treatment in renal cell carcinoma. So this is why we had the Keynote 564. This trial included patients with clear cell carcinoma with or without sarcomatoid features, and a patient should fulfill the definition of high-risk criteria. As Dr. Fahad mentioned, we should pick patient with high-risk feature. Patient received pembrolizumab 3 weekly for up to 1 year, 17 cycle versus placebo. And there is some comment about this issue. Should we bring patient who is free of disease apparently for receiving some hydration in the placebo arm? However, this was the design of the trial. And the primary endpoint was disease-free survival. And also there was another comment, should we take disease-free survival as an endpoint per se, or this should be a surrogate for overall survival? However, in most of the adjuvant trials, we use the disease-free survival because we can have low number of patients and faster results, so the drug can just come up to market in a fast way. Here, this is the, I mean, details of the eligibility criteria and exclusion criteria. I will not go through it, but I will just explain the high risk definition. We have 3 categories: patient with intermediate high risk, includes those with T2, grade 4 or sarcomatoid, or T3 regardless the grade, T4, and there is a high risk group including T4 regardless the grade, or any patient with positive lymph node. And the third group is patient with metastatic disease who underwent metastatectomy and no evidence of disease. This can be done within 1 year of the nephrectomy. Coming to statistical consideration, actually the first interim analysis should be done when we had 260 plus disease-free survival event after a follow-up period at least 12 months. It was done in at 15 months, and then if the null hypothesis was rejected, then we can move to the alpha can move to the overall survival. Let us see the patient characteristics. Here we can see that the majority of a patient were intermediate high risk, about 86%, and 3/4 of the patient was PD-L1 positive. And here we can find that the majority of the patient were T3, about 90% or 89% of the patient, and lymph node for those patients was only in about 6%, sarcomatoid and 10%. Coming to the patient disposition, we can find like 300 patients in the pembro arm completed their treatment while 200 was discontinued, and none of the patients in both arms was on going treatment at the time of the interim analysis. Coming to the primary endpoint, which is disease-free survival, the disease-free survival endpoint was met in this trial, and we can find a hazard ratio 0.68. And we can find also early separation of the curve at the first assessment at 12 weeks, and the 2 years landmark difference was about 9.2% from 68 to 73%. At the end of the curve, we can find some crossing. However, this is due to limited patient at risk and the need for longer follow-up. And actually, there was an update for this trial. Median follow-up at 30 months was presented in the ASCO GU, and here we can find the curve is really frankly separated. Hazard ratio is 0.63. So no doubt that this treatment just did improvement in the disease-free survival. And the difference in the disease-free survival reached to 11%. Coming to the subgroups, we can find in the subgroups, in many of these subgroups, there is evidence of treatment effect homogeneity in those patients in the confidence interval higher limit is less than 1, and this in favor of the pembrolizumab. However, many of these subgroups were inconclusive, but we can say that the mean hazard ratio is stable across the whole subgroups, and it doesn't matter if patient with CBS positive, PD-L1 positive or negative. Of course, here in the PD-L1 positive, they showed a more strong result. Coming to the subgroups, the intermediate versus high risk versus the M1 net, we can find patients with intermediate high risk, they achieving hazard ratio 0.68 and the difference of 9.1 versus the placebo group. In the high risk, overall the outcome is bad. 48.7% of the patients, they were disease-free at 2 years, but the differential in comparison to the placebo was for the sake of the pembrolizumab was a difference of 13.3%. And in the patient with M1 net, they achieved the highest improvement with a difference of 40% versus the placebo. And as also Dr. Fahad mentioned, the higher the risk, the higher the benefit of the adjuvant treatment, which is very logic. What about sarcomatoid? Patients without sarcomatoid, they achieved hazard ratio of 0.63 and difference of 10%. And those with sarcomatoid feature, usually more nasty disease, they achieving a higher result, hazard ratio 0.54 with a difference of 19.8%. Coming to the overall survival, usually the overall survival is the ultimate goal in most of the clinical trial, especially in the adjuvant. However, we can see here in the first interim analysis, the overall survival was still not mature because only 26% of the overall survival event was done. And in the mature result after 30 months follow-up, also still 33% overall survival event. And so still we cannot just draw a conclusion. We have to wait for more mature overall survival result. If we look at, also they were very active in this trial. Tony Shweri also presented, in the last ASCO, the time for first subsequent treatment, and it showed also improvement for the sake of the pembrolizumab arm. 77 patients received the first subsequent treatment in comparison to 110 patients in the placebo arm, and most of those patients received anti-VEGF. Only about 8% in the placebo received the immunotherapy, and 4% in the immuno arm received immunotherapy. And also this is a very common question, what to do if the patient failed post immunotherapy. There will be also some maybe discussion about this issue. Another also, efficacy parameters with the progression-free survival too. Also, it was delayed in the pembro arm versus the placebo, and the distant metastasis-free survival also was delayed with the pembrolizumab, and the difference of 10.2%. If we look at the recurrence event, we can find that 19.2 distant and local relapse in the pembro in comparison to 28.1 in the placebo arm. Coming to the toxicity, because if we offer treatment to the patient without gross disease, really toxicity must be tolerable. And as we can see in the extract with adjuvant SOTANT, the toxicity was really beyond tolerance. This is why we were reluctant to use SOTANT. If we look here at the pembro, we can find that grade 3-4 toxicity overall is about 32%. The serious one is 20%. And the one related to the treatment is about 18%, 19%. And this related to immune-related adverse effect is about 8.6%. And even in the mature result after 30 months follow-up is still stable. So this is really what we expect from immunotherapy, that the overall side effect is not exceeding from 10 to 20%. So we can say that this is really more tolerable than SOTANT. Most of the side effects were fatigue, pruritus, and hypothyroidism. Coming to the other item, if I will offer a patient adjuvant treatments, quality of life must be good, must not deteriorate. Otherwise, I'll bring a patient without a gross disease and I will ask him to receive a treatment, which I don't know exactly what it will do, and it can affect the quality of life. I will just go fast in this because this is really long. We can see regarding the symptomatology, there was no deterioration in the symptoms of patients who received the pembro in comparison to the placebo, although there is some sort of numerical difference, of course, for those with placebo arm. Coming to the quality of life, many items like the gross health score, also there is no deterioration. Coming to symptomatology, overall there is no difference either with the QLQ. And here this is analytical study. Also, they showed overall the bottom line that there is no deterioration for the quality of life. I will just run because of time. So coming to the clinical guidelines for adjuvant setting, here if we compare SOTANT versus pembrolizumab, we can find the efficacy. It is there in disease-free survival with SOTANT and also in pembro. Treatment burden and the cost, both of this treatment, one of them is oral, but with a lot of toxicity. The other is intravenous. Patient should come every 3 weeks. However, tolerability is a little bit better than SOTANT, but also it is costly. And really, we are the overall survival will just finalize this debate. However, so far we can find the pembro has an upper hand over SOTANT. And if we look at the guidelines, the NCCN guidelines, we can find that the recommendation to use pembrolizumab in patients with high risk criteria, and also in the ESMO guidelines and in the European Association of Urology, they just recommend for those patients that better to offer the patient pembrolizumab rather than offering any of the TKI. And if somebody just mentioned, what about overall survival? Still, if later on there was any negative reading with overall survival, maybe there will be a reversal of this. But so far, pembrolizumab is just doing fine with a patient with high risk criteria. And there is many ongoing phase 3 adjuvant and neoadjuvant trial, like the Rampart trial using Durva and tremelimumab, Atizo also is there, and Anivo with everolimus in the average just was presented by Dr. Fahad. And in conclusion, Keynote 564 is the first positive phase 3 trials of adjuvant immunotherapy in renal cell carcinoma. It showed improvement in disease-free survival at 24 and 30 months of follow-up, hazard ratio 0.63. The benefit was consistent across all subgroups, including intermediate high and metastatic NET and sarcomatoid subgroup. Adjuvant pembrolizumab prolongs the distant metastasis-free survival time for first subsequent treatment, BFS2, and also there was no deterioration in the health-related quality of life and the patient outcome. Overall survival is still immature, and we are awaiting the final result of the overall survival. Till we got this, still pembrolizumab is recommended by the all guidelines to be offered for patients with high-risk criteria. And by this, I would like to thank you.
Thank you very much, Dr. Ahmed, for this kind presentation. And if you agree, we will take 5 minutes to discuss this two first paper.
Thank you very much, Ahmed, and thank you very much, Dr. Husseini. Just due to the schedule change of the flight arrangement of some of the speakers and the chairs, as Dr. Husseini said, we'll take 5 minutes of Q&As for the adjuvant part of the presentation. And if you allow me, Mr. Chairman, I'll start with asking Fahad, and the same question will apply to Ahmed Rifai about their views of using adjuvant therapy in renal cell carcinoma. We know that in the past we had certain failed trial with bazopenib and etc., exitinib, and now everolimus, though the outcome, the result was not positive, and now the pembrolizumab. So we'll start with Fahad in order of presentation. So what do you think?
Thank you very much, Isam. So adjuvant treatment in kidney cancer is unmet need. And we see some patients who are high risk and wants to prevent recurrence and improve outcomes in kidney cancer. And I'm really happy that now we have more and more evidence in these trials. Now we know more. Our insight about this treatment is better, yet the results are only disease-free survival, and only the benefit is in the subgroup, the real benefit in the subgroup of the very high risk. So for the everolimus, it's negative basically, although it applies same, only higher risk. You subgroup them, there is really clear benefit, but then that's only a subgroup. If Ahmed will allow me, I will comment also in the keynote study. It's better data. The study was clearly positive, and I'm happy now that I have an option for those patients who are asking for it. So Ahmed showed elegantly there was no deterioration in quality of life. Probably the side effects of interest, especially for you, Isam, is the financial toxicity. I know, but at least we have something for these patients at this time. So one more point about the Everest study. We're not going really to look for further and further follow-up of this study. The median follow-up time was 77 months, so 6 years. While the keynote study still, Ahmed very elegantly presented 30 months. So maybe some waiting will give us more clue.
Thank you. Ahmed?
Yeah, thank you, Dr. Assam, for the question. Thank you, Dr. Fahad, for his answer. Really, what is meant by adjuvant treatment? Adjuvant treatment means that we are treating, visible distant metastasis, or local relapse. So we are treating these which we cannot see, but is there. But really, we don't know which patient who will get the maximum benefit from the adjuvant, because many of the patients actually is cured by the surgery. So we can expose some patient to over treatment with adjuvant treatment, which they don't need. We don't really know exactly which patient, but as Dr. Fahad mentioned, maybe we pick the patient with high risk for recurrence, those patients who can, had the best outcome. The second issue is to design a good adjuvant treatment. This means you have certain prerequisites. First of all, the treatment must be effective. We can see in pembro it is effective. Number two, the treatment must be tolerable, because patient would receive treatment for 1 year. If it is not tolerable, this is really, it will be difficult to to explain it to the patient, offer him a treatment, which I can defer it till the patient develop metastasis and offer him the treatment. Something else is about the financial toxicity or the utility outcome. Still, this treatment are, also with financial toxicity. So actually, adjuvant trial usually is difficult trials because really we don't have a model to pick the best patient for the adjuvant treatment. And the last issue is about the overall survival. If the overall survival, the disease-free survival was not translated to overall survival, this can just collapse everything, because someone can say, okay, I will not offer any treatment to the patient till the disease progress. By this time, I can start the treatment. And really, we have 3 upfront nice protocols, all of them the combination of using immuno with TKI. And something else, still we don't know what is the answer for those who will progress after the adjuvant treatment. Can we use immunotherapy again? Still, so far, what we will do to be pragmatic, we will just follow the guidelines, and those with high risk, we can offer this treatment. But still, there is also concern among the oncologists.
So one more point, if you allow me, Assam, to add. So it's clear from all the adjuvant RCC trials, there is some uncertainty. All of them, were not clear in recommending adjuvant treatment, at least not for everybody. And it's a commitment, at least, and to me, the number one burden besides the side effects is the commitment that the patient will make for 1 year. So I think it's important to share with our patients this uncertainty about overall survival and the magnitude of benefit in disease-free survival and the side effects and the duration of treatment. And when it comes some area of uncertainty, I'd love to really engage my patients in making the decision for himself. Thank you.
I couldn't agree actually more with both of you. And now we'll go back to the track. Thank you, Fahad. Thank you, Ahmed. But Ahmed, Fahad got a plane to catch up with after almost like 2 hours. You should stay with us for the discussion at the end, please. Okay, and I'm sure that the adjuvant will represent other discussion points with the other eminent speakers to come. Now it's back to the chairpersons to go ahead with the program.
Assalamu alaikum. So our next speaker online again, Dr. Mubarak Al-Mansour. He is consultant and head of oncology, adult medical oncology in King Abdulaziz Medical City, National Guard Hospital in Jeddah. Dr. Mubarak will talk about the phase 3 trial with 2x2 factorial design of abribaton acetate plus prednisolone and or radiotherapy in MCSPC, first results of piece 1. So the mic is yours, Dr. Mansour.
Bismillah ar-Rahman ar-Rahim. Salatu salam ala Rasulullah. Sahbihi wa sallam. Good morning, everyone. And thank you for Dr. Issam, Dr. Mirvat, and the members of the organizing committees. And thank you for the chairpersons for the kind introduction. I will be presenting the phase 3 trial with the 2x2 factorial design of abiraterone plus prednisone plus or minus radiotherapy in men with the de novo metastatic castration prostate cancer. And this study, presented in ASCO 2021 and updated also in ESMO. And due to the importance of this study, and a kind of one of the practice changing for a certain patients, it was selected by the scientific committee to be presented again and to have a more discussion around this trial. A very rapidly evolving standard of care for men with a metastatic castration sensitive changed over time. You can see from this slide that in 2013, the standard of care for a patient with a metastatic castration sensitive was just only ADT, either LHRH agonist or antagonist. And then in 2015, by the Charted study and the GTAG and Stampede, docetaxel was proved to be one of the options for a patient with a metastatic castration-sensitive prostate cancer. And then 2017, abiraterone also moved from the castration-resistant to the metastatic stage. And then in 2019, we had Enza and Enzolotomide. So we have a multiple options. So you can see over time, the standard of care was changing. And that's, if you see the accrual of the PEACE-1 study, it started in 2013. So that's why you will notice later on that there is a change into the standard of care from ADT to ADT plus docetaxel. And that's a few or a portion of patients received ADT alone. And then later on, docetaxel was optional and then was a mandatory as a standard of care. So the PEACE program, this is a prostate cancer consortium in Europe, and the aims and goal for that program is to conduct phase 3 studies in prostate cancer. And PEACE-1 is one of the products of that program. And as you know, presented twice by Karim Fazazi in ASCO and ESMO. So this is the design of a PEACE-1, included a patient with a metastatic castration-sensitive, those with one or more of a bony lesion and a bone scan or CT scan, a good performance status 0 to 2. And then they allowed a patient to be on ADT less than 3 months to be a part of that study, and then was randomized to 4 arms, the standard of care, and I will elaborate more into the standard of care type, because as was mentioned initially was ADT and then later on docetaxel. The second arm is standard of care, which is ADT plus or minus docetaxel plus abiraterone, and then a standard of care plus radiotherapy and a standard of care plus abiraterone and radiotherapy. The stratification was by the ECOG performance status, metastatic site, type of castration, and also a docetaxel given or not. So the standard of care, ADT, either LHRH agonist or antagonist, plus or minus docetaxel. We are saying here plus or minus because, as mentioned, in 2013, ADT was alone, and later on, docetaxel was added. The experimental arm was the abiraterone, the usual dose, 1 gram, plus the prednisone, 5 milligram BID. And the radiotherapy, a 74 gray in a 37 fractions. More into the standard of care between November 2013 and 15, ADT alone. So about 273 patients received only ADT in that clinical trials among all the 4 groups. And then in 2015 and 17, docetaxel was permitted as part of standard, so a kind of optional. And between that time of 15 and 17, 591 patients, and between 17 and 18, docetaxel was a mandate part of a standard of care, so 300. So that's why you notice a change into the standard of care from ADT alone, then to be a docetaxel-based protocol. Primary endpoints, the co-primary radiographic progression-free survival according to the prostate cancer working group criteria, and a PSA level or and overall survival. So those are the co-primary endpoint. They listed a lot of the secondary endpoints, including the castration-resistant free survival, the prostate cancer-specific survival, time to the next survey, and you can see the list of the other secondary endpoints. This is the statistical analysis, and you can see they put it in a 2 abiraterone analysis or radiotherapy question analysis, and we'll see later on how did they do that in stages. But abiraterone, they put the radiographic progression-free survival, overall survival. You can see the 2-sided alpha level. And if you combine both, it's a 0.05. So they divided the alpha level, which is the 5% between the overall survival and radiographic free survival. That's to make sure that they are not inflating the alpha level and making sure that the multiplicity of the endpoints is not affecting the study outcome. And power, as you can see, 80%, and hazard ratio assumption they assumed that a 40% reduce in radiographic progression-free survival with abiraterone compared to the standard of care, and a 30% reduction. So testing the interaction and controlling type of the type 1 error, they put it in 3 steps. The first step is to test if there's any interaction between abiraterone and radiotherapy. And the point is that you remember, like we had 4 arms at the time of the study, which is standard of care plus radiotherapy, or abiraterone, or standard of care plus docetaxel. So radiotherapy, just I will show, yeah. So just make sure that the radiotherapy, there is no interaction between the radiotherapy and the abiraterone, because if there is interaction, then they will present each arm separately. If there was no interaction, then both arms, which include the radiotherapy, they will put it in a one-pooled analysis with the abiraterone. And the second step is testing the abiraterone for radiographic and overall survival. So there was no interaction. And the third step to see abiraterone and docetaxel into the docetaxel population. So the first step, there was no interaction detected between the effective local radiotherapy and that of the abiraterone, which means that adding radiotherapy or not to the abiraterone arm did not affect the analysis. They put both groups together instead of analyzing each group separately. And so the 2 arms of the abiraterone arms for analysis. And that's what I mean here. You can see in each arm about 290 something. Now they combined both arms with a standard of care plus abiraterone, or standard of care plus abiraterone and radiotherapy. The same in this one, the standard of care alone, or standard of care plus radiotherapy. This is the baseline characteristics, and this is a median follow-up initially in the first presentation in ASCO was 42 months. You can see the median time from diagnosis about 2.3 months, and the disease burden, which is important, a high volume in about 57% among both groups, and docetaxel 60% between the both groups, so as that was given as part of the standard of care. No differences between the baseline characteristics between the 2 groups. The median time for the overall survival, 36-35, and the median number of docetaxel cycles were given 6, so which include that there was no any problems with the interruptions or the discontinuation. Most of the people in both arms received 6 out of 6 docetaxel, and the median time to abiraterone discontinuation 31. So this is the primary endpoint initially presented in ASCO 2021 with the radiographic, and this is all overall population, so not just only a docetaxel. And you can see the hazard ratio 0.54, so a 46% reduction into the risk of radiographic progression-free survival with abiraterone compared to the standard of care alone. And you can see the median here, we are talking in years, not in months, so 4.5 years compared to 2.2 a month, so about 2.3 years of differences in overall population that include the ADT alone or ADT plus docetaxel in one arm. The subgroup analysis, you can see clearly that it was inside of the abiraterone among all the subgroup analysis, including the radiotherapy, docetaxel, performance status, metastatic high versus low volume, and also the Gleason score. So that effect on a radiographic progression-free survival was clearly demonstrated and favoring the abiraterone arm plus docetaxel. The overall survival, and this is from the ESMO 2020 first, also by Karim Fazazi, because initially the overall survival in the first presentation was not matured at that time. However, a few months later, they presented the overall survival benefit, and the hazard ratio 0.75. So 25% reduction in the risk of death with abiraterone plus docetaxel compared to the standard of care alone. And the differences you can see here was not reached into the abiraterone arm compared to 4.4. And if you see it clearly into the docetaxel arm, especially with the high volume, so a 53% reduction, which is higher than the whole population in that high volume. And the difference is 4.1 years compared to 1.6 years. So a huge difference into the radiographic progression-free survival and also into the overall survival, almost 1.5 year difference between the docetaxel plus abiraterone compared to the docetaxel and ADT. This is in the docetaxel population. And then the other listed secondary endpoint, which is the castration-resistant prostate cancer-free survival, which means the time from the initiation of the treatment to the reaching to the castration-resistant. For sure, they would expect that will be a longer period with the abiraterone arm, which is the case, 3.8 years compared to 1.5 years. So those patients who started in abiraterone, they have a longer time to reach to the castration resistance compared to the standard of care alone. The same was for the docetaxel population, 3.2 years compared to 1.4, and the hazard ratio here is 0.38. Exploratory endpoints, including the overall population with the clinical progression-free survival, again demonstrated to be higher into the abiraterone arm, 4.3 years compared to 0.1, and also into the docetaxel group specifically, so 4.1 compared to 1.9. And you notice that each time into the docetaxel arm, either the primary or the secondary endpoints were higher when specifically to the docetaxel arm. Again, because if you included those overall population, you included a patient just only received ADT and not docetaxel. But in this, you are talking about specifically about the patient who received the docetaxel as a part of a standard of care. Grade 3 and 4, 5 toxicities, febrile neutropenia, there was no risk in abiraterone arm higher compared to the standard of care. So addition of abiraterone did not increase the risk of febrile neutropenia. However, you would expect that hypertension will be higher because of abiraterone, and the liver toxicity, so 6% compared to 0 and 12 compared to 8. And the GI toxicities in both are more or less the same. So addition of abiraterone maybe would have impact on the hypertension and liver toxicities. And this is the overall survival results also presented by Karim Fazazi, just to compare the change into the magnitude of the overall survival. So when the ADT was used alone at that time into the comparator arms into the charted and GTAG, the median overall survival for those patients with ADT is 33 months, and then a docetaxel was about 40 to 48, and the abiraterone arm into the latitude and stampede also prolonged the overall survival to 50 months. And now we've seen with the ADT plus docetaxel plus abiraterone, the overall survival reached almost 61 months in that group, and that was demonstrated specifically for the high risk. So in a conclusion, adding abiraterone to the ADT plus docetaxel significantly improved both radiographic progression-free survival and overall survival in men with de novo metastatic prostate cancer, and all secondary endpoints, progression-free survival, the castration-resistant prostate cancer survival, and the symptoms defined clearly improved, and no meaningful additional short-term toxicity with abiraterone compared to the standard of care. And I think we'll have maybe more discussion into the discussion part. Thank you so much.
Thanks, Dr. Mubarak. as usual for this nice elegant presentation. So we'll move to next speaker. Next speaker will be Dr. Mohammed Al-Ghamdi. He is a medical oncologist, deputy director and head of medical oncologist in King Saud University City. Dr. Al-Ghamdi will present to us updated overall survivor in the MET trial in metastatic hormone sensitive prostate cancer. Dr. Al-Ghamdi, mic is yours.
Thank you so much for the nice introduction. Thank you, Dr. Issam, Dr. Mirvat, for the invitation, and I must congratulate both of you for the excellent, as usual, conference. So I have been asked to talk about the ENZAMET updated survival analysis that was presented in the last ASCO 2022. So basically, this was presented by Professor Davis on behalf of the ENZAMET Investigators Group, which is the Australian group in collaboration with Ireland, the Canadian, as well as Dana-Farber. So so we know now the current management of metastatic hormone-sensitive prostate cancer. When we see patients with low volume, we know that they're going to do better than those with high volume. And this is always prognostications, variables that have been associated with better outcome with only testosterone suppression. We know also that when patients presented with de novo metastatic synchronous disease, they do worse than those with metachronous. On multiple trials that have been shown, and as presented elegantly by Dr. Mansour, we know that addition of docetaxel to testosterone suppression is actually better than testosterone alone in both groups, synchronous, metachronous, and high volume. We know that, let's call it the strong ADT, so the testosterone suppression with abiraterone, enzalutamide, or apalutamide, it's better than the testosterone suppression in all groups. Radiation to the primary with only testosterone suppression versus testosterone suppression only also showed a benefit in those with synchronous low volume disease. Recently, as we have heard from Dr. Mansour about PEACE-1 and also another study, Addison, that was presented, looked at the triplet treatment, and we know that it's better than docetaxel versus docetaxel with testosterone suppression. But we don't know whether a strong ADT with a docetaxel is better than a strong ADT alone. So the ENZAMET was actually presented back in 2019 with the interim analysis after 3 years of follow-up, and it was positive in terms of overall survival. And here they presented the latest update after 68 months. And basically, you all know that it was 2 arms, the testosterone suppression with the standard or conventional non-steroidal androgen deprivation therapy, were either beclotamide or the old ones, compared to addition of enzolotomide to those, and the allowed docetaxel. And we're going to talk a little bit of an update of docetaxel arm. So that was the initial interim analysis. It was positives in terms of overall survival with a hazard ratio of 0.67 for all the subgroup. And there was also a strong signal in favoring the triplet treatment, basically the enzolotomide, testosterone suppression with docetaxel. Few unanswered questions that need to be addressed. So the long-term outcome and whether the PFS benefits those with triplet therapy would actually translate into overall survival. And how about the subgroup outcomes, the high versus low volume, the synchronous versus metachronous. So this is the data cut off in January 19, 2022. Median follow-up, as I said, 68 months. 470 deaths happen. And basically the subgroup analysis also, they looked at the effectiveness of enzalutamide when combined to docetaxel, and they looked at two factors for prognosis: M1 at initial diagnosis, so synchronous or de novo, and high volume versus low volume disease. So again, enzalutamide did show an improvement in survival, and this is the updated one, hazard ratio of 0.70. The enzalutamide group median survival did not reach versus 73 months with the control arm. We're going to see how many patients actually crossed to other, let's say, strong ADT medications in the upcoming slides. The 5-year survival increased by 10% when enzalutamide added. So I believe the reason the conventional treatment, they did very well because almost more than 75% of patients did actually cross when they progressed to either enzalutamide and abiraterone and also other options. And obviously it's less than those patients on, it's more than those patients on enzalutamide. So Enzamid was actually representative for all subgroup of patients, those with synchronous, metachronous, high volume, low volume use of docetaxel. We know that the docetaxel use was actually a choice. It was not really mandated. There was a 45% plan for concurrent docetaxel up to 6 cycles. And before just the randomization, about 108 patients did receive actually 1 cycle of dosi, and 62 received 2 cycles. So the design allows having patients can be on docetaxel. So this is just to show you the pre-specified subgroup analysis for the docetaxel, and as you can see, for overall there was a benefit. Was it an early versus delayed docetaxel? There was some differences, but what really matter is the volume of the disease and the synchronous versus metachronous. As you can see here, from this chart, we know that addition of docetaxel to enzalutamide versus the enzalutamide alone versus the others was more pronounced benefit seen in the synchronous high volume and the synchronous low volume, but wasn't really seen in those with metachronous in either group, with exception of just the conventional treatment. And here is the PSA progression-free survival, and again, synchronous, they have the best outcome, although it was comparable, the Enza versus Enza with dosi versus the other options. And we need to just remind you that these results based on just subgroup analysis, and it was docetaxel was not actually mandated or randomized patients. And this is what they mentioned in their limitations. So the strength of this is actually the active control on the outcomes was actually compatible to what we have. The concurrent use of docetaxel was allowed because of standards of care, as we have seen with piece 1. Dr. Mansour presented that in 2015, they actually amended their protocol. The outcome of the synchronous, metachronous, high volume and low volume, and it has a hard endpoint, was overall survival. So some of the limitations, again, docetaxel was not really randomized. It was not, the study was not powered for the subset analysis, and we do not really confuse treatment effects with other different prognostic groups. And the clinical impressions, it did confirm the benefit of Enza and those with castrate-sensitive prostate cancer, especially in low volume, and the analysis suggests additional benefit when added to docetaxel. So to conclude the study, enzolotomide, when added to testosterone suppression, did actually improve the overall survival significantly. They mentioned that the study is still ongoing, and the benefit we're seeing most apparent for those with low volume, and those for whom docetaxel was not really deemed necessary. That's the confusion now that we are living now. When are we going to use the triplet versus the doublet treatment? Triplet means adding chemotherapy. This is just to show you the what we have for the doublet treatment, the ABA, the ENZA. So all of them did actually show an overall survival. Some of the other agents have other secondary endpoints or co-primary endpoints like radiological progression-free survival as well as PFS too. Looking at the latest guidelines from the NCCN, again, doublet is still the standard of care. Probably we're going to have more data for the triplet, and it will have its way of in the management of prostate cancer. And this is the acknowledgement for patients, participants, investigators from the author. Thank you so much.
Thank you, Dr. Al-Ghamdi. And we will open the session for 2 questions because Dr. Al-Ghamdi also again had the flights. So if anyone had a question for Dr. Al-Ghamdi. Check online if there is any question online, Dr. Murshid, maybe. Yeah, the question for Dr. In view of Endomet trials that failed to show benefit of triple therapy, how you interpret this result with other positive study and when you choose triple therapy? Dr. Al-Ghamdi.
That's a very good question. So if we look at the other positive studies, the PEACE-1 and ARISON, so it has different stratifications, randomized, controlled, well-designed study. But if you look at the Enzamet, docetaxel was not actually randomized. So different populations group, different statistical analysis. That's probably the reason that we are seeing different results. But I agree with you. We cannot really compare trials with each other, others, especially when it's not really a well conducted.
Thank you. Any more questions? So without any further delay, so we'll move my mic to my colleague, Dr. Franz.
Now we will move to the second session, discussion abstract with an international expert, Dr. Henri Grandet, Director of the Medical Oncology Program and the Clinical Research Lead, MD Anderson in Madrid, Spain. Dr. Henri.
Thank you so much and good morning, everyone. Salam alaikum. This is my great pleasure to be here with all of you. Well, unfortunately virtual, but hopefully, inshallah, next year we can be all together there. So my challenge today is to talk about what are the practice-changing trials that has just been nicely summarized before a great speaker. So they did my job very, very easy. So we have 3 abstracts to discuss that are changing the practice, are changing the approaches of patients with renal cell carcinoma in the adjuvant treatment and patients with metastatic hormone-sensitive prostate cancer in daily practice. So let's focus first on the keynote 564. Let's focus first on the patients with renal cell carcinoma, the new treatment algorithm that we have in the adjuvant setting. These are my disclosures, and of course, I would like to thank you to the organizers for kindly inviting me. I'm delighted to be here. Okay, so we have a new indication. Pembrolizumab, a PD-1 inhibitor, an immuno-oncology drug, is now approved for patients with intermediate and high risk of relapse with clear cell renal cell carcinoma. This is the main message. But the key thing here is, okay, can we squeeze the data? can we really go beyond the data and try to see who are the patients in daily practice that are really benefiting from this approach? And I think the first question that we should ask ourselves is, do we need adjuvant treatment to treat patients with renal cell carcinoma? And definitely the response is yes, we need it. Take a look at this graph because it was presented as a poster at ASCO 2022. And I think this is important to realize that we really need adjuvant treatment for some patients with very high risk of relapse. This is, in a retrospective analysis, the outcome that we observe in patients with PT3 tumors. So patients with large tumors going out of the capsule of the renal capsule. And as you can see, not all PT3 tumors are behaving the same in terms of risk of relapse. Take a look at how important is the pathologist report at this point. Those patients with T3 grade 1 and 2, the overall survival, the proportion of patients that are relapsing is very low if we are comparing with those patients with PT3 tumors, but with grade 3 or 4. So the report from the pathologist, the multidisciplinary team, it is extremely important. And the pathologist report is really conditioning us in order to select or not a patient to receiving adjuvant treatment. So we need to go beyond, we need to discuss into the multidisciplinary team who are the patients that are really benefiting. Okay, you can say, okay, but these are patients that are, well, an overall population of patients with PT3 tumors that they are relapsing or not. Okay, take a look at this other graph from the same poster reported at ASCO 2022, in which we can really ask the question of, do we really need adjuvant treatment to our patients in daily practice? Definitely yes. Take a look at the magnitude of the benefit, depending on if the patients are relapsing or not with PT3 tumors, and according to the grade of histology. If the patients are not relapsing, we can say that they are alive, they will be alive for many years. They will not be dying because of renal cell carcinoma. However, if the patient, unfortunately, are relapsing of this primary tumor from the kidney, unfortunately, the death rate, the overall survival will be dramatically deteriorated. So, if we are able to avoid relapses, we will be able to save lives. This is the question here. Do we really need adjuvant treatment in patients with renal cell carcinoma? My response, and this is a personal opinion, is definitely yes. We need drugs to improve the overall survival of our patients, but we need drugs to avoid relapses in this scenario. Okay, unfortunately, and the history has been disappointed. And I would say that consistently, all the tyrosine kinase inhibitor tested in this setting, sunitinib, sorafenib, pazopanib, axitinib, sorafenib in this field, unfortunately failed in demonstrating the primary endpoint benefit. And the primary endpoint of all these trials was consistently considered disease-free survival. It has been nicely summarized before, the results of the Everest trial with everolimus. And as you can see here, well, almost everolimus hit the difference for disease-free survival, but unfortunately, well, not statistically significant. We need to discuss the clinical relevance of this data and definitely the toxicity associated with everolimus when given in the adjuvant setting. It is not really, well, make the good balance in between good risk-benefit scale to the treatment of everolimus. The keynote 564, this is the design. It has been nicely summarized before. So I'm not gonna get into details, but I want to point out, I want to highlight what is the definition for intermediate and high risk patients recruited in this trial was considered. Patients with intermediate high risk were those patients with PT2 tumors, but with grade 4 histology or sarcomatoid component, or patients with any PT3, and we observed before that not all those patients with PT3 tumors, the risk of relapse is equal. Patients with high-risk tumors were those with PT4 stages or lymph nodes involvement, and very high-risk tumors, I would say, those patients with metastasis fully resected, R0, N1 patients. So all these patients should merit from pembrolizumab in the adjuvant setting. I would say that probably we will need to discuss internally into the multidisciplinary team, case by case, who are the patients that are benefiting from receiving pembrolizumab. These are the data. Primary endpoint was met, disease-free survival consistently, and the longer is the follow-up, the more consistent are the results. While pembrolizumab is impacting in the disease-free survival, and it has been approved because of this hazard ratio of 0.63, very good for progression-free, for disease-free survival. I want to point out as well, and I think it is clinically relevant and important from daily practice. The highest is the risk, the better is the hazard ratio for disease-free survival with pembrolizumab. So those patients with M1 fully resected tumors, the hazard ratio is amazing, 0.28. So very good. I don't have any doubt. Today, in my practice, I am routinely offering pembrolizumab as an adjuvant treatment in those patients with metastatic tumors fully resected. Another question or another debate is, okay, synchronous versus metachronous metastases should be treated, should be managed in the same way? Okay, we can discuss that later. Those patients with high-risk tumors, I remember, PT4 and lymph nodes involvement has a ratio of 0.6. No doubt about that. So if you have a patient tomorrow in your clinical practice with PT4 tumors or with lymph nodes involvement, definitely they should go for pembrolizumab in the adjuvant treatment. Hazard ratio of 0.68 was observed for patients with intermediate and high risk. And probably this is not the same, all PT3 tumors versus PT2 with grade 4 or PT2 with sarcomatoid component, because probably these tumors with these molecular and histological features are conditioning for a worse prognosis. So once again, this multidisciplinary team discussion should be taken before offering pembrolizumab for this particular scenario. I don't have any doubt that those patients with sarcomatoid features should go for adjuvant treatment. Pembrolizumab, as you can see here, with a hazard ratio of 0.54, is benefiting to those patients with sarcomatoid component, regardless the PT stage. So I think this is practice changing, and I don't have any doubt to offer pembrolizumab in daily practice to these patients. Tony Chueri reported that these ASCO 2022 data that are consistently with a longer follow-up with the primary outcome of the trial. Distant metastasis-free survival was better with those patients receiving pembrolizumab. And the overall survival, we can say that it is not yet statistically significant, but it goes in the best direction. Hazard ratio 0.52. I think this hazard ratio, this is not statistically significant. Once again, and I want to stay clear for this, not statistically significant yet, but clinically relevant. And I would say clinically, the trend from the clinical perspective goes in the good direction in this sense. Time to second occurrence of disease progression, I think it goes in the same direction than overall survival. And the treatment the patients receive when metastatic, well, they are reflecting the doubts that we have, how we should face, how we should approach to these patients relapsing to pembrolizumab in the adjuvant treatment when they are becoming metastatic. Well, patients who relapse receive everything, receive tyrosine kinase inhibitor single agent immune-oncology drugs, I don't know why, combinations of TKI plus immune-oncology drugs, or even combination of two immune-oncology drugs in this field. Well, we will need longer follow-up to see if these patients are behaving differently in the metastatic setting if the patient received before. Another thing that it is important to bear in mind in daily practice in the adjuvant treatment is about the toxicity, because this is not just about how active these new drugs are in the adjuvant treatment. This is also about what is the quality of life of the patient, what is the toxicity we have. Well, we know because we have a lot of experience dealing with single-agent immune checkpoint inhibitors. No unexpected adverse events were found in the adjuvant treatment when using pembrolizumab. And I would say that, okay, around 20% of the patients are needed to withdraw the drugs because of immune-related adverse events, but this is not really conditioning the quality of life of the patient. So I would say that pembrolizumab is active and relatively well tolerated. New guidelines, the ESMO updated guidelines, are recommending to consider the use of pembrolizumab in patients with intermediate and high risk of relapse with clear cell renal cell carcinoma. And it is recommended the use of pembrolizumab in the adjuvant setting for patients with M1 fully resected tumors. This is completely practice changing. What about the American guidelines, the NCCN guidelines? They are not based on the stratification factors considering in the keynote 564. They are just recommending in those patients with stage 3 the use of pembrolizumab, and they are suggesting the use of pembrolizumab in patients even with stage 2. I am more related with ESMO guidelines, and I think the multidisciplinary discussion in between pathologists, urologists, oncologists on which are the patients that are really benefiting this kind of treatment, I think it is should be mandatory. This slide has been shown before, and I think it perfectly summarizes what is the current setting, the current scenario, the current environment that we have in the adjuvant treatment of patients with high-risk renal cell carcinoma. Pembrolizumab and sunitinib are both approved by FDA. Only pembrolizumab is approved by both FDA and European Medicine Agency. Based on the efficacy in terms of the primary outcome of the trial, disease-free survival, however, none of these two drugs have already improved overall survival from the statistical perspective. In terms of toxicity, I think pembrolizumab is much better tolerated than sunitinib in this field. And I think the access, the cost to pembrolizumab should be discussed internally on each country. So my conclusions in the adjuvant setting for renal cell carcinoma, and this is a personal view, so you can criticize all of these slides that you want. Pembrolizumab can be considered right now a standard of care, but today no single agent has improved overall survival so far in the adjuvant setting. We still don't have an agreement of what's intermediate versus high risk for relapse tumors. So we need to base on the design of the trial, but this is not really fully reflected that we saw in the major international guidelines. And this is not consistent with the use of adjuvant treatment in other trials. 1 year duration of the adjuvant treatment is enough or too much. Why not, instead of 12 months, 6 months, or why not 2 years? I don't know. What is the risk in terms of toxicity we want to assume as acceptable? 20% of patients unfortunately withdraw the treatment because of the toxicity. What's the cost we can afford as acceptable in absence of overall survival benefit? Important to reflect that. Lack of any reliable biomarker, even we don't see any at all that could be potentially used in medium and long term. We need biomarkers, molecular biomarkers that can help us to identify these patients in daily practice. And from my second part, prostate cancer. Very quick, very fast to do this summarize. We have that triplets are entering into the standard approach of patients with metastatic hormone-sensitive prostate cancer. We have seen how Dr. Al-Mansour and Dr. Al-Mahdi has done a great summary of these two pieces of works, piece 1 and Enzolotomide. However, we need to put this data into the context of what we have, what other options we have for the treatment of patients with metastatic hormone-sensitive prostate cancer. We have docetaxel single agent, we have abiraterone single agent, enzalutamide in the Arches trial single agent, apalutamide in the Titan trial, and now we have 3, not only 2, 3 phase 3 trials showing evidence that triplets should be added to the armamentarium that we have. Enzamed with enzalutamide plus docetaxel, piece 1 abiraterone docetaxel, and also the recent Arasens darolutamide plus docetaxel in this field. Dr. Al-Mansour did a great summary of the piece 1 trial. Nice summary, much better than me, just to reflect that in the subgroup analysis of patients only treated with docetaxel versus docetaxel abiraterone, okay, the results were recently published at Lancet, And as you can see here, the addition of docetaxel and abiraterone to standard ADT is impacting in the overall survival of the patients. I think there is a kind of synergy in this particular subgroup of patients consistently in all subgroup analysis here. And if we squeeze and torture the data, probably those patients with high volume are the ones that are benefiting more from these triplets in daily practice. We need to remind that PIS1 trial is an academic phase 3 trial conducted by the G2 group in France. And well, for me, this graph is very clinically relevant. And for me, PIS1 trial is now reference standard of care for patients with hormone sensitive metastatic prostate cancer first, second, high volume, and third, synchronous metastasis from the beginning. Let me remind what is the design of the ASCO trial. The ASCO trial is a phase 3 trial, registration trial, pivotal trial for the combination of both darolutamide and docetaxel together with ADT. So this is a prospectively, I would say, well-designed trial. This is not an academic trial. So this trial is really addressing the question if the triplets are impacting or not in the overall survival. Well, 2/3 of the patients, they have high volume, and all the patients receive docetaxel from the beginning in combination. So all these issues that Dr. Mubarak Al-Mansour mentioned before about the design of the trial, the changes in the design, well, have not seen in the ASCO. ASCO, the triplets of darolutamide, docetaxel, and ADT are clearly impacting in the overall survival with a hazard ratio of 0.68. Statistically significant, and the most important thing, clinically relevant. So the triplets are working in these tumors. And no matter if the patients have de novo metastasis or a metachronous metastasis on these patients. What about the use of enzalutamide? We have not only one, not only the Enzamet, we have 2 phase 3 trials here supporting the role of enzalutamide in this field. The ARCHES trial, only enzalutamide versus ADT alone, or the Enzamet trial, enzalutamide with or without docetaxel versus ADT alone. Well, the ARCHES trial has recently demonstrated to be superior in terms of overall survival. So Enzamet is one standard of care in this setting. Enzalutamide as a single agent is one standard of care in this setting. Hazard ratio 0.66. Remember before 0.68. So I think there is no doubt about the use of single agent novel hormone therapies, at this time enzalutamide in this field. What is Enzamet adding here? Well, Enzamet is adding that the use of concomitant docetaxel was allowed when used enzalutamide for the treatment of patients with metastatic hormone-sensitive patients. In the overall population, Enzamet is a positive trial. Take a look once again, hazard ratio 0.7, consistently with the other hazard ratios that we have. But when we go in deep to the subgroup analysis, we can see that the use of early docetaxel, well, it is still benefiting to the patients, but we need to identify, we need to be very careful when offer these triplets based on enzalutamide to our patients. Probably those patients with a lower tumors, with the lower volume, are the ones that are benefiting more. Who knows? I don't think that makes sense from the clinical perspective. If we go to the subgroup analysis of those patients who received docetaxel, well, it seems, and I don't know what clinical sense it has, that those patients with the lower volume of disease are the ones that are benefiting more from the triplets. Well, I am honestly supporting more the use of abiraterone, according to the results of the PIS1 in combination with docetaxel or darolutamide with the ARASENS to the data that we have with Enzamet in this field. Well, what about the use of docetaxel, the triplets in patients with synchronous or metachronous metastasis? Well, consistently are benefiting here. This graph is probably the only that is making me to doubt here and to say, okay, probably there is a subgroup of patients that are benefiting more from the triplets based on enzalutamide. Those patients with synchronous metastatic hormone sensitive stages and high volume. Probably I will discuss about this, but probably, well, PIS1 is a little bit ahead. The discussion of Enzamet at ASCO 2022 did these take-home messages that I fully support and endorse. Enzalutamide was superior in overall survival versus ADT alone in patients with metastatic hormone-sensitive prostate cancer. Longer follow-up has helped to clarify the benefit of those patients using concomitant docetaxel here. Enzalutamide, well, is one of standard of care. However, we still need more rationale. We still need more data supporting the use of triplets. Once again, there was another trial that was another study that was reported at ASCO 2022, and I think it is important because consistently, well, PIS1, ARASENS, and Enzamet are impacting in the radiographical progression-free survival, and overall survival has just been hit by PIS1 and ARASENS only. But can we translate? This is a good surrogate endpoint for overall survival in patients with metastatic hormone-sensitive prostate cancer, and it seems it is. So probably, if we are hitting radiographical progression-free survival, probably we are hitting also OS. When we put all this data into context, well, it is not really to make conclusion from this. This is just hypothesis generating, but we have a broad range of options that we can use in our patients. ADT alone can be still considered from some particular frail patients with a lot of comorbidities in the metastatic hormone-sensitive setting. Abiraterone single agent, docetaxel single agent, apalutamide single agent, enzalutamide single agent can be considered here, probably and with no doubt for patients with low volume, for everybody with novel hormone agents, and for patients with high volume with docetaxel single agent. And the upcoming use of triplets here are supported by 3 phase 3 trials. PIS1, ARASENS with darolutamide, and Enzamet with enzalutamide. Probably those patients with synchronous metastatic hormone-sensitive stages and high volume are the ones that are benefiting more. However, we need still longer follow-up. This is my last slide. The top 5 questions in this field. Do all patients with metastatic hormone-sensitive prostate cancer benefit from ADT intensification? When should we use triplets therapy? How to choose in between the different triplets that we have? Is there any role for molecularly targeted precision medicine here? PARP inhibitors are approved. Radioligands, the VISION trial, are approved in the metastatic castration-resistant setting. Are they going to be able to pass into the first-line metastatic hormone-sensitive stage, and how can we accelerate the innovation? Thank you so much to all your attention, and I'm happy to receive all the questions that you may have. Thank you.
Thank you very much, Professor Grandi. Please invite all the speakers now to the podium, whether physical or virtual, to be part of the discussion. Just to catch up with our previous point when the presentations were made for the role of adjuvant therapy in renal cell carcinoma high-risk patients. And we asked the guys of their insight and what their views in this. The same question goes to Dr. Mansour and to Professor Grandi. So, Mubarak.
Thank you, Isam, and thank you, Dr. Grandi, for the excellent presentation. I think that was one of the best about the view about both the adjuvant and also the triplet therapy. And I cannot agree more about the triplet therapy. I think that was nicely summarized in those patients with the high volume and with the synchronous. And I think what we need now, at least into the triplet therapy, we have overall survival benefit and radiographic progression-free survival benefit and selected group. And in our practice, unfortunately, we don't have yet a kind of a biomarkers apart from the clinical assessment, which is taking into account the high volume and the synchronous plus the fitness of the patient to receive the triplet therapy by adding the docetaxel in terms of the performance status, comorbidities, and the other elements. So yes, fortunately, we have now more options to offer to our patients with the high risk metastatic castration-sensitive prostate cancer, and I will consider this triplet therapy as for very selected patients based into the clinical Disease and patient's characteristics.
Professor Grandi?
Fully agree with my friend, Dr. Mubarak Al-Mansour. I think this is important to discuss these cases into the multidisciplinary team. Not all patients with prostate cancer, they are fit enough to receive docetaxel. So triplets, this is true that they are very well tolerated. They are not really adding synergistic toxicity, but triplets are hard to tolerate for some patients, frail, with older than, I would say, 80 something years old, So we need to discuss, we need to be very sensitive in daily practice to know in advance to select who are these patients. And I fully agree. Those patients with synchronous metastasis from the beginning, those patients with high volume, fit enough to receive the docetaxel are the best candidates to receiving these triplets. And for me, this is practice changing. For me, I have patients in my daily practice using these triplets so far.
Thank you. Dr. Basleman?
Yeah, thanks, Dr. Grandi. Just, I would like to ask a question regarding, can we use any approach to choose who's the patient or the population that we will use the triplet? For example, we know from the Charted trial, the patient who had a good BSA responder, who's good responding in the first 7 months, they have the better overall survival. Can we use this approach to who's the patient will intensify and who's will not intensify with chemo or not?
That's a great question. Let me respond with a clinical case and the last patients that I was using the PIS1 schedule in my practice. That was just 2 weeks ago. This is a very young patient, 57 years old. This is the CEO of a company, so the level of knowledge, the education level of the patient is high enough to understand that this is not yet approved because we still don't have the approval for these triplets. But in my opinion, this is the best approach that we have. These patients with 57 years old, well, he has an echo performance status of 1 because of bone pain at the hip of the patient, and in the bone scintigraphy, well, it was almost fully covered by bone metastasis, the bone scintigraphy, almost fully covered. I did an NGS testing, and the patient has a mutation in BRCA2. He has a medical history about that. He has no really visceral metastasis at all, but because of the, good performance status, very good shape in 57 years old, is starting to have symptoms because of the bone metastasis, high volume because of these widespread in the bones of the patient, and the patient has enough knowledge or enough education to understand what I am offering, despite not being in the level of the drug so far. So this is the perfect scenario to use the triplets at least in my opinion, in the daily practice.
Thank you. Any more questions, Dr. Faris?
About the renal cell carcinoma, we know that most of the surgery, even in Europe, done by urologists which not expert in oncosurgery. Do you think that the surgery, the quality of surgery could play a role or affect the result of the study because there is no any verification of the quality of the surgery before inclusion in the study?
Absolutely, and this is something that we should try to avoid in the clinic. Well, the more experience of the surgeon, the better clinical outcome of the patients. This is pretty clear. However, I would say this is not a matter. The less experience of the surgeon, is conditioning for the more radical nephrectomies performed. The thing here, when you are operating a patient with renal cell carcinoma, is to try to preserve the kidney or the majority of the kidney, the largest part of the kidney. I mean, the more experience the surgeon have, the more partial nephrectomy, preserving the function of the kidney to the patient they have. This is more related to the quality of life, the future quality of life of the patients, rather than the quality of the oncological surgery, if I explain myself. Do you know what I mean?
Yes.
Another question here is about the retroperitoneal lymphadenectomy. that it is not routinely done. And the experience is once again conditioning that those surgeons with experience, they have more knowledgeable in terms of, well, to see if they need to reset or not the retroperitoneal lymph nodes of the patients.
Yeah, I have another question, please, about I have some concern about the quality of life in the keynote adjuvant therapy in RCC or all the other clinical trials. I have some difficulties to accept or to understand how in the experimental arm, there is 30 or more than 30% of toxicity, immune toxicity or other toxicity. In the other hand, placebo, there is no toxicity and the quality of life is never affected.
It's because these immune-related adverse events are conditioning the quality of life of a very small subgroup of patients, probably less than, I would say less than 15% of the patients. So this is not really translated into the overall quality of life that you can see in the graphs. If you just focus on those patients in which you need to withdraw the treatment because of the toxicity, probably you will see a dramatic deterioration in the quality of life. A skin rash, it is not severe, but this is dramatically affecting to the quality of life of the patients. Diarrhea, it is not severe in the majority of the cases, but it is conditioning highly the quality of life of the patients. And of course, all the endocrinopathies, you know, things like that are conditioning for asthenia, and they are conditioning for taking pills, definitely conditioning for the deteriorated quality of life of the patient. So I would say in the majority of the cases, more than 80% of cases receiving adjuvant pembro, the quality of life will be very good. However, be careful, because unfortunately we cannot predict who will be these 15–20% of the patients with deterioration in the quality of life with high toxicity because of the use of pembrolizumab in the adjuvant setting. In absence of a good predictor of toxicity to immunotherapy, well, I would say that, well, I am offering routinely pembro to my patients.
Thank you very much. I think it's almost 11:45 where we have to close the session. Thank you for all the speakers. Thank you for all the chairpersons. And without any break, we'll move into the next session. Shukran.
Thank you.
Thank you so much. Okay, now it's time to go ahead with the first satellite symposium of today. This symposium is sponsored by Astellas. Thank you for their sponsorship. Our speaker will be Dr. Bassam Basleiman. Bassam is a consultant medical oncologist at King Fahad Medical City with a special interest for breast cancers and GU, almost the same as my practice. And Bassam is a graduate of King Saud University. I will not say the year, so we will not say that he's younger than us, but he is almost like 15 or 20 years younger. And he finished his internal medicine board, the Saudi board, followed by acquiring the Saudi fellowship in medical oncology from King Fahad Medical City. And then he acquired 2 fellowships, or 3 fellowships actually, in GU, in thoracic oncology, and breast cancers. And he's going to talk to us about the recent updates on the management of metastatic hormone-sensitive prostate cancer with a case presentation. Bassam, you have 30 minutes, please. Go ahead.
Assalamu alaikum. Thanks, Dr. Assam, for this introduction, and I would congratulate you for organizing this education and lovely event. So, in the beginning, I would like to thank Astellas for inviting me today for speaking about the recent update in metastatic hormone-sensitive prostate cancer. And I would like, it's already discussed in the previous session. And here I would like to make just to close rephrase it for discussion, and I will end by case presentation. Next slide. Okay. So this is my disclaimer. So as a background at the beginning, so this is the last registry for the Saudi cancer registry in 2016. And as you can see here, prostate cancer in all adults represent the 10th rank with around 405 patients. And they represent the 3rd rank on the male Saudi males or Saudi men. And we know that the peak incidence, the incidence at the age of 70, we can see it, and usually start to be after 60s. Once we compare it with the age standardized rate with for the Saudi Arabia with other countries, we can see here Saudi Arabia is 6.3 rate compared to the developed country, which is reaching to hundreds or 70s. And this can be because of the screening programs associated in these developed country, or the population of the population in this country usually more older in the age compared to Saudi Arabia. Once we see this the stage distribution for prostate cancer, the distant or the metastatic stage is represent 35%, with more compared to the developed countries. And we noticed there is one data that showed that the incidence of prostate cancer increased from 1990 to 2016, from 150 cases to around 1,300 cases. So there is around 8 times increase over the last 15 years. Here, as we all know, the effect of castration on the prostate cancer, which is presented by this landmark study was 18 years ago by Dr. Huggins, and who won a Nobel Prize for this discovery. And it showed that the testosterone androgen is it's the main factor or the dependent factor for the prostate cancer. And which showed that you help to control the disease, and but eventually this will cause castrate resistant. So this is the mechanism of action. The testosterone is the main dependent factor for the prostate cancer, was produced by the testis by 90 to 95%. There is 10 to 5% from the adrenal gland, and this is regulated by the hypothalamus pituitary axis, which so and by use medical therapies, medical castration like GnRH agonist, which is the most commonly used, can help to reduce or suppress the testosterone, and this eventually will control the prostate cancers. Comparing surgical castration versus medical castration has the same effect, as you can see here from this 2 studies, which is 1990s, 1995s, and intensifying these castration, medical castration or surgical, with a 1st generation androgen receptor and antagonist, we call it previously as a complete androgen blockage, didn't show any meaningful overall survival benefit. So mostly we'll use the ADT alone. And the spectrum of prostate cancer has multiple spectrums, but I choose these 3. We have the localized disease, which has the better survival, the metastatic hormone sensitive, which represent 45%, and worse survival with the castrate resistant. And there is a good number of patients with localized will be transferred to be hormone sensitive, which is around 35%. One of the important things we'd like to notice in my presentation is the difference between de novo and localized. And this study, they found that they divide the patient depending on at presentation. Are they metastatic at presentation, or are they localized disease and then develop a metastasis? There is they include around 190 patients. 60% of them died from the prostate cancer, and they found that patients who had de novo metastatic cancer have a significant worse overall survival than the one who had a localized disease at presentation. So from 1940 to 2015, the ADT alone is the main standard therapy for the hormone-sensitive prostate cancer. But the survival is still disappointing once we treat it. And this is, I will show you two trials. One of the SWAG trial, S8894, showed that 77% of the patient has a survival less than 5 years. And only 7% of them, they will live for 10 years. And the de novo metastatic, there is another trial from this Stampede, this one, showed that the median overall survival for the patient who treated with ADT alone is only 42 months, is 3 years and a half. And the failure-free survival is around 11 months. So the hypothesis here, that we know that prostate cancer is heterogeneous. Some of them, they have good response. Some of them, they have poor responder. So this can be addressed by the combination strategy than using only monotherapy. And that's why there's a shift in the focus toward preventing, delaying the resistance with the combinations. So for a lot of therapies that used in the castrate-resistant docetaxel, abiraterone, ablotamide, enzolotomide, shifted to be used in the hormone-sensitive setting. And this is what happened from 2015 till today. We have a lot of combinations approved now in the metastatic hormone-sensitive setting: docetaxel, abiraterone, radiation, enzolotomide, ablotamide. So just in brief, I would like to review these data. The first one is using the docetaxel to the addition to the ADT, and we have two landmark trials here. We know it. Actually, there is 3, but I will show only the 2: the Charted and the Stampede. That both of these trials, in brief, showed that there is improvement of overall survival with adding the docetaxel with around 10 months. In both trials, would improve the hazard ratio around 30 to 40%. Once we see in deep, as this is a retrospectively, they did for the Stampede, they did retrospectively seeing who's the patient who has high burden and low burden, and there is a good number of the patient didn't know which volume of the disease for them, and they found that regardless of the volume of the disease, the docetaxel would show benefit. But that's not true in the Charted. In the Charted, they found that the benefit is mainly for patients who had a high volume disease. The low volume didn't show any major benefit from adding the docetaxel. So in summary from the docetaxel, what I would like to show that the volume of disease is not related to the sensitivity of docetaxel. But patients with low volume in the Charted and the French trial, the G2G AF15, safely defer the docetaxel to be used in the castrated system. So I think for low volume, I will try to avoid using the docetaxel for them. And what we saw in the Stampede with the benefit that in the low volume, I think because the trial didn't address this question from the beginning. So that's what, and the number of the patients is small here compared to the other trials. So now going to the, other than chemotherapy, we're going to the androgen receptor targeting agent. We have multiple agents approved in this setting. We have the abiraterone acetate, which is studied in two studies, Latitude and the Stampede, which include patients who had high-risk prostate cancer, metastatic, hormone sensitive. And both of the study was positive, showing improving in the overall survival by around 10 months, with a hazard ratio almost the same, 0.62 and 0.63 for the both trial. In ESMO 2020, we have the updated result from the Stampede, who compared the abiraterone, added the abiraterone to the standard of care. And after 6 years follow-up, we can see here the adding the abiraterone improved the survival by around 2 years and a half. So the abiraterone 6.6 compared to 3.8. So we are crossing the minimum that we saw with the ADT. The ADT, the median was around 3.5 years. Going to another agent, enzolotomide. Enzolotomide was studied in 2 different studies. We have the ARCAS and the Enzymet. The ARCAS they have the same population. They include patients who had metastatic hormone sensitive, and they started the ADT, and within 3 months, they add the enzolotomide. And they standardize the patient depending on the volume of the disease, and they allow for using the docetaxel. And the patient, they take enzolotomide with ADT versus placebo with ADT. And we can see here that the ARCAS showed that met the primary endpoint, which is in the ARCAS was the radiological progression-free survival, with the median radiological progression not reached when the enzolotomide versus placebo was 19 months. The overall survival, the last update for the ARCAS was last ESMO 2021, and showed that the overall survival after follow-up of 4 years, that there is 71% alive with the enzolotomide arm, compared to 57 on the placebo arm. And we can see here in the subgroup analysis that the benefit even seen in patients who had low volume or high volume, regardless that the patient has M1 at diagnosis or M0 at diagnosis. So either de novo or localized at the beginning, the benefit is clear, but more pronounced in patients who had M1 or de novo metastatic prostate cancer. The other study is the Enzolotomide. Here is different compared to the ARCAS a little bit. The ARCAS, they use a placebo as a control arm. Here they use the standard non-steroidal and anti-androgen. So like biclotomide, nalotomide, furotomide. So they compare it with another medication. And they include the same inclusion criteria, the same stratification. And here the primary endpoint is overall survival, which radiological progression-free survival was on ARCAS. And the primary endpoint was met here in Enzolotomide with improved overall survival, reaching median 80 months versus 72 months in the non-steroidal anti-androgen with hazard ratio 0.67. They allow in this trial for the docetaxel, and this may be explained before by Dr. Grandi. And once we see the high volume and low volume, so let's concentrate on patients who had docetaxel, who had 71% of them, they have high volume disease. The progression-free survival was positive, but the overall survival was negative, but hazard ratio is 0.9. And the patient who had no docetaxel, the high volume was lower. So the docetaxel here not randomized, they allowed as the physician choice. So 37% of this had volume. And the same we are seeing, that we can see here that the overall survival is more pronounced with the patient who are receiving the enzolotomide, comparing compared to the group who didn't use the docetaxel. In last ASCO, just 4 weeks ago, we have the updated results for the overall survival, and they released some data about docetaxel, which presented just 30 minutes ago by Dr. Grandi, that the longer overall survival after 60 months or 66 months, we can see here the benefit of adding enzolotomide in the first line is still maintained. So after 60 months follow-up, 67% of the patient will be alive, and 50 at once adding the enzolotomide, and 57 with the non-steroidal anti-androgen. And the median here doesn't reach for the enzolotomide, but it's 73 months for the control arm. Once see the subgroup analysis for patients received docetaxel or not, we can see the benefit is the same, is continued regardless patient received docetaxel or not. And the volume of disease, either patient had low volume or high volume, the benefit of adding enzolotomide is there. For one of the things that they presented in the enzyme, maybe Dr. Al-Ghamdi and Dr. Grandi, they discussed it before, the volume and the timing of metastasis and docetaxel, once we compare it with the other arms. So if we divide if I have 4 arms, enzolotomide alone, enzolotomide with docetaxel, non-steroidal anti-androgen, and non-steroidal anti-androgen with docetaxel. So let's concentrate on the gray curve. We can see in the patient who had high volume and synchronous, which we know had the poorest prognosis, they have the higher benefit from adding the docetaxel to the enzolotomide. And this maybe give us who's the population that will get the benefit from the triplet therapy. The fourth agent can intensify the management of prostate cancer is the ablotomide, which is studied in Titan. They have the same population, but they allow to adding the ablotomide within 6 months from starting the ADT. So, and they randomize the patient either ablotomide versus placebo with the ADT. And the primary endpoint was co-primary, overall survival, and radiological progression-free survival. And the primary endpoint was met here with improving the overall survival and radiological progression survival with adding the ablotomide. And this improvement also shown in the overall survival. As we can see here, even the subgroup analysis for the high and low volume, the benefit is still there regardless the volume of disease. So the doublet therapy for metastatic castrate-sensitive prostate cancer, all patients are all eligible patients should be offered the treatment intensification upfront. The choice of agent regarding docetaxel, abiraterone, ablotomide, or enzolotomide is dependent on the cost, adverse event, and contents of patient comorbidity. Docetaxel is the least expensive, but has completed after 6 cycles, so there is a duration to be used, and it will be offered for patient chemo fit. The abiraterone is required monitoring for blood pressure, LFTs, and electrolyte, and there is a concern from the hypertension and prednisolone monitoring. Enzolotomide and ablotomide has less monitoring required, and there is a concern with the enzolotomide for the neurocognitive issue and also for the ablotomide with adding the rash for the ablotomide. Going to the last thing, which is the update in the last 2 years for the intensification of management of metastatic prostate cancer, which is the triplet therapy. So these already discussed with Dr. Al-Mubarak in detail, just in brief. The basic study presented by Dr. Fizazi last ASCO, ASCO 2021, which is a 2x2 design, and the co-primary endpoint is progression-free survival and overall survival. They randomized the patient to 4 arms: abiraterone with radiation, abiraterone, radiation alone, or standard of care. All of the arms had a standard of care. But what's the standard of care? The standard of care has a little bit difference here than usual. They allow the evolving of a standard of care during the treatment, the clinical trial. So initially was ADT alone in the first 2 years. After that, in 2015 to 2017, docetaxel allowed to be used as the physician's choice. And in the last 2 years of the clinical trial, 17 and 2018, docetaxel was mandatory as a standard of care. And docetaxel was used in the statistician as a stratification factor. So here the primary analysis of the co-primary endpoint of progression-free survival and overall survival with adding the abiraterone to docetaxel. And it showed that clear benefit for the progression-free survival by around 2.5 years. And the overall survival by the median didn't reach for the abiraterone and 4.4 for the standard of care with hazard ratio 0.75, which decreased the risk of death by 25%. And this benefit is, if we see the sub-analysis, we can see in the metastatic burden for patients with low volume, the benefit of adding abiraterone to docetaxel is less clear. What about toxicity from adding this combination? As discussed before, hepatotoxicity, we have to monitor the LFTs with abiraterone and the hypertension. And lastly, in the last ASCO, the ARSENS trial, which is assessing the darolutamide with once added to the docetaxel. So both of the arms are using ADT with docetaxel, and the control arm has a placebo, and the study arm is having the darolutamide. And they include all the patients with metastatic hormone-sensitive prostate cancer. The primary endpoint was met here with positive study with the addition of darolutamide to the ADT docetaxel significantly reduced the risk of death by 32%. And it's important here to mention that 75% of the patients in the placebo arm receive a subsequent therapy. So this is important, that intensification has impact on the survival in the earlier line. All the secondary endpoint here, we can see it's more beneficial for the darolutamide, adding darolutamide to the docetaxel and ADT. The safety, the major safety that we see with adding the ADT, adding the darolutamide or the novel androgen inhibitor is the hypertension, as you can see here, 6 versus 3%. And the liver enzyme is a little bit higher, as we saw the abiraterone. So here, all the trials, we can see intensification in the management of hormone-sensitive prostate cancer, increase the survival, regardless what type of therapy that we use. And the hazard ratio, as you can see here, almost all of them between 0.6 and 0.7. So what is the benefit of triplet therapy? Overall survival benefit for adding abiraterone or darolutamide to the ADT and docetaxel doesn't address the benefit of adding docetaxel to the ADT and abiraterone. So we don't know how the chemotherapy will add the benefit here, because the docetaxel was included in both arms, the control and the study arm. So still, this question need to be answered. The second one, we know some patients had the low volume chemo unfit or had exceptional responders. What's the benefit from using the triplet therapy on the radiological progression-free survival? Still, the level 1 evidence now, still the standard of care till today from all the guidelines across Europe and North America, using the doublet agent, ADT with one of the 4 agents. The triplet therapy, I think it's coming. And we will soon have the FDA approval and the guidelines will be changed, but still not now. What's ongoing, what's coming for metastatic hormone sensitive? There is a lot. We have the immune therapy as combination with enzolotomide. We have the B10 capivasertib, B10 inhibitors, capivasertib, or the PADRM inhibitor, talazobirib, niraparib. Also the PSMA, we saw the PSMA lutetium efficacy in the castrate resistant. It can also, there is ongoing trial in the metastatic hormone sensitive. What's gap is still there. We don't know how to choose which the intensifier we will use. We have multiple, and I think the cost and patient preference side comparability is the most direction to choose between them. And when should we use the triplet therapy? Still not clear to answer this question. And lastly, we are this is unmet need. We are the role of molecular target precision medicine here, which may help us who will be use the intensification or the triplet therapy, and who will use the doublet therapy. Here I'm coming to my case. So this is one of my patients, which I saw him last Thursday. Mr. M is an 80-year-old gentleman, known case of hypertension, chronic kidney disease. The baseline creatinine is around 300. Was following with urological clinic at local hospital for urinary retention. And we're investigated and showed that in October 2019, showed that there is BSA 140. And so subsequently they have a biopsy. And the biopsy showed prostate adenocarcinoma with Gleason score 4+4, grade group 4. And the bone scan done for him and the CT scan and the MRI pelvis showed that there is one or solitary bone metastatic in the right ischium. The MRI pelvis confirmed the same with pelvic lymphadenopathy, and the CT chest showed no visceral metastasis. So what we have here, it's oligometastatic de novo prostate cancer with the baseline BSA 143 and Gleason score 8. So started initially on the ADT monotherapy, which had a very good response, and later, subsequently, enzolotomide added to the ADT in 3 months from the starting the ADT, and also we offered the prostate radiation in February 2020 with the seminal physicals by around 60 gray in 20 fraction. You can see here how is the drop in the BSA. So within 7 months from starting the ADT, the PSA is normalized, and he is maintained undetectable till last blood workup done on June 13. How is the toleration of the therapy? The patient tolerated the therapy with no significant side effect during his therapy, so no dose reduction. And during his therapy, the blood pressure was a little bit going up. He was on nifedipine, 30 milligram to control blood pressure, was getting up. And once we review the nifedipine with the enzolotomide, we see that there is an interaction between the nifedipine and enzolotomide, because the enzolotomide is one of the CIB3A4 inducer. So, and this will decrease the efficacy of nifedipine. So we had to modify the dose of nifedipine here to control the blood pressure. So I encourage all to, once we start the enzolotomide, to do review the medication of the patient, see any drug, any medication interaction with the enzolotomide. Also use the help of clinical pharmacists here to review the medications. Here one trial that I didn't mention it before about the use of the prostate radiation for the low volume metastatic hormone sensitive prostate cancer, and the STAMPEDE trial showed that it's clearly improved the overall survival. So here I'm reaching to my last slide, the conclusion. Docetaxel or abiraterone with EDT in metastatic hormone-sensitive prostate cancer, especially patients with good performance and high volume disease, using this and needed here to close monitoring for the side effect and the need for the steroid. Enzolotomide and or abiraterone are a safe option across the disease volume subtype regarding low or high volume, with no need for the steroid and less monitoring. The clinical gestalt and the comorbidity side effect profile, cost, patient preference should be taken into consideration when deciding which systemic agent to be combined with ADT. And lastly, triplet therapy, it will be a new standard of care for the metastatic hormone-sensitive prostate cancer soon. And thank you.
Okay, thank you, Bassam. Very nice and elegant presentation as usual. We'll keep close together. If any question, any online question, guys? Okay, so let me just ask one or two. What's your experience with enzolotomide in terms of hypertension? I know in the literature it's said that it's about 7 to 10%. So to my surprise, in my experience, I didn't see anything related to hypertension or increased blood pressure. So what was your experience in that?
In my experience, the hypertension, I didn't see, it's reported that the hypertensive crisis is around 7% from the literature. But in my experience, I didn't see increasing the blood pressure. But I'm watching for monitoring the blood pressure during these. But I'm not seeing it's one of the major problems here.
Another thing about the triplet therapy. Do you think that our patient will tolerate triplet therapies, docetaxel?
Yeah, in Saudi Arabia, as I mentioned, the peak of age is 70s, and usually in this population, I don't think they will be fit for the triplet. So mainly, I will offer the triplet for patients younger. I saw 2 weeks ago a patient 60 years old with prostate cancer, metastatic. I think these patients fit younger age. I will offer, but most of our population, yeah, it's elderly and as I'm fit. Like my patient now, 8 years old. I don't think he will be fit for the triplet.
And how many of you are fit for docetaxel even as a single agent with ADT?
Maybe it happened the last year, one patient that he had hormone sensitive.
It's almost the same practice everywhere. Okay. Any other question? I do believe that if none, we'll call the session for an end. Thank you, Bassam. Thank you very much. And now we will move with the second satellite symposium. And it's my pleasure to introduce our chairman for the next satellite symposium, Dr. Mirfat Mahrous. Mirfat is the conference. She is the conference actually. Okay, in simple words. Mirfat.
Thank you very much, Dr. Morshid, for excellent session and a great discussion. We'll go for the second slide symposium by STADA team. And it's my pleasure to introduce Professor John Avis Play. John Avis Play is known for everybody. He is medical oncology consultant in France, and he is a director in Lyon Center. And also he is working in Comprehensive Cancer Center in Lyon University and professor at University of Claude Bérard, France. So he will give us a talk about trabectedin as a treatment of sarcoma state of art. Professor Play, floor is yours. Thank you so much for joining us.
Thank you very much for the invitation. First, I'm very happy to be with you, even in virtual presence. It's really a pleasure to be here with you today. What I will actually do is quite simple during this half an hour. I will share with you most recent data on trabectedin. And we will see together how sarcoma are both a complex world, in particular in advanced phase, and a topic where targeted treatments and early treatments, such as trabectedin, can really make a big difference. Oops. Let me take control of the slides. Thank you for the invitation. These are my disclosures, both as an investigator and also as a director general of this hospital, as just mentioned. There are 4 ideas on sarcoma. The first one is that these are rare tumors, and this is absolutely true. The overall incidence is less than 6 per 100,000 per year. Second one that it is an heterogeneous group of disease, and that's also true. Over 150 different histotypes have been identified in the most recent WHO classification. Despite of that, there is similar local treatment, and now, as we are going to see, systemic treatment, which are becoming more complex and also more effective for the treatment of patients in advanced phase. During this presentation, I will use the guidelines of the NCCN and of the ESMO as basis for our discussion. And of course, these guidelines are very consistent in many chapters, and I will share with you some of the questions which are still unsolved. So sarcoma represents a very heterogeneous set of disease. The majority is actually ultra-rare sarcoma with an incidence inferior per 1 per million. And because of that, we really need to have central pathology review in order to get the best diagnosis. The threat of patients with sarcoma is to have an inadequate diagnosis, and central pathology review by a sarcoma expert is probably the most reliable strategy in order to be able to have the most accurate diagnosis and not to misdiagnose lymphoma or carcinoma with sarcoma, or even different sarcoma subtypes across the different WHO classifications. In front of this complex histological and molecular review, we have a remarkably simple strategy for the treatment of patients in localized phase. Biopsy first, adequate imaging, staging, en bloc surgical resection by a trained surgeon, followed or preceded by radiotherapy, with neoadjuvant and adjuvant chemotherapy, which can be considered. And this has been a topic for the last 40 years, actually. Who are the patients we should give adjuvant or neoadjuvant chemotherapy is not indicated in the guidelines. What we all know is that not all patients are candidate. Some patients are candidate, but a precise definition of the good candidates are still pending and require further investigation. And this is, of course, related to the complexity of the disease. Nevertheless, we know that neoadjuvant treatment can provide significant improvement of both tumor control and overall survival. And as an introduction to what I'm going to say in the metastatic phase for trabectedin, it's important to have in mind that in this randomized study testing neoadjuvant treatment, which was reported by our colleagues from the Italian sarcoma group, Spanish and French sarcoma group, the observation that trabectedin was the only agent which proved to be as effective and probably as effective and better tolerated than doxorubicin ifosfamide in a neoadjuvant setting for this specific histological subtype of myxoid liposarcoma was worth considering. So neoadjuvant and adjuvant treatment can be used, and trabectedin is demonstrated to be an active agent for some histological subtypes. What about management in advanced phase? I think it's important to stress one thing, which is despite what is available on the internet and what quite often the patient come to see us, sarcoma in advanced phase is a curable disease, and patients with advanced disease can enjoy prolonged life with conserved quality of life. And some of the agents, including trabectedin, are able to provide that. And this example of a patient doing triathlon when receiving trabectedin, I think is a very good example of what we can achieve for some patients, unfortunately not all patients. And this has been reported actually for a long period of time. This was a paper published actually some 20 years ago by the EORTC soft tissue and bone sarcoma group, showing quite consistently, and this has been reproduced several times, that about 5 to 8% of patients with advanced sarcoma are alive progression-free at 5 to 10 years. These patients are CR patients, but also PR patients and patients with stable disease. We do not know exactly what is happening in this patient, what is biology underlying this long-term survival, but we know that quite consistently they are existing. So our goal is to put ourselves in a situation to give the best treatment to our patients as early as possible, and to enable them to live as much as possible a normal life. So what is the standard first-line treatment? Standard first-line treatment, doxorubicin base. Combination with ifosfamide? Yes, why not? But the objective in this case is to increase response rate and to provide prolonged progression-free survival. At the end of the day, overall survival remains similar in this classical randomized study, which was reported again by the ORTC. Does gemcitabine docetaxel, which is quite used in some countries around the world, provide similar results as compared to doxorubicin-based regimen? The answer is clearly no. Here, this was a study conducted by the British Sarcoma Group, a randomized study comparing doxorubicin versus gem docetaxel, which showed that the gem docetaxel was not only not superior in terms of efficacy, but also associated with a lower quality of life and less favorable side effect profile. So this puts us in a situation to say that doxorubicin base is still the standard first-line treatment. After that, what do we have? We have approved agents, doxorubicin, pazopanib, eribulin, and we have non-approved agent, but demonstrated to provide some activity in generally academic studies, randomized studies. Gem docetaxel, as mentioned, gem DTIC are example, paclitaxel for angiosarcoma. What is the evidence on trabectedin, which was approved for the treatment of advanced STS, leiomyosarcoma, and liposarcoma in the United States, all histological subtypes in this context? It started with a pivotal STS-201 study in soft tissue sarcoma in advanced phase, comparing doxorubicin 3-weekly versus trabectedin 3-weekly versus trabectedin weekly, demonstrating quite nicely that actually progression-free survival and overall survival, even though this was a trend, was superior in the 3-weekly. But of course, a major evidence came out from the 3007 randomized clinical trial, which was conducted worldwide, comparing trabectedin 3-weekly versus dacarbazine. In this study, the primary endpoint was overall survival. Progression-free survival was found to be significantly superior in patients treated in this randomized study, leiomyosarcoma and liposarcoma, even though the primary endpoint of overall survival was not reached. The demonstrated evidence that trabectedin is active in this group of disease was brought by this important clinical study. And not only the progression-free survival was superior in the trabectedin arm, but also overall response rate and clinical benefit rate, including in the long term, looking at 6 months, for instance. All right, third major clinical study, a randomized clinical study conducted in Japan, testing trabectedin versus best supportive care in patients with advanced translocation sarcoma. In red, patients treated with trabectedin. In blue, patients treated with best supportive care. The difference is a major difference for progression-free survival. Difference is a major difference for overall survival. It's important for this patient population to give the treatment early and to provide the treatment as quickly as possible, including in second line. We conducted a similar study in all comers of sarcoma histotype at the request of the French agency, comparing trabectedin 3 weekly versus best supportive care. And again, best supportive care was found very significantly different as compared to trabectedin, which provided some long-term responders, some patients who are still doing well in this randomized clinical trial. Remember that patients were proposed for crossover in this setting, and crossover being proposed to patients who were, of course, progressing in the best supportive care arm. We gave 6 courses, but should we give more than 6 courses? The TEDIS phase 2 randomized study addressed this important question. After 6 courses of trabectedin, should we continue as maintenance, as suggested by the 3007 clinical study, randomized clinical study, and the Japanese study, or should we interrupt the treatment? The TEDIS randomized phase 2 studies demonstrated very nicely that actually it was important to continue the treatment for a longer period of time. More than 6 courses provide prolonged progression-free survival, and even though we can restart the treatment after progression if the patient has stopped trabectedin for a given reason, that's still a very nice demonstration that the patient benefit from this maintenance treatment. What about real-world data? We know that from real-world data, experience are extremely helpful to help us better define what is the best treatment for the patient. And this was conducted in several instances in different countries around the world. We started in France with this retrospective study, which showed, as you can see on this slide, the very high response, progression-free survival, and median overall survival in patients treated quite early. And in particular, the observation that the outcome of patients in this real-world data set was actually superior to what was observed in patients randomized into the different clinical studies, which is not unusual, I must say, in the world of sarcoma. In this study, we also observed that all sarcoma histotype we tested, which were in sufficient number, seem to derive some important benefit in terms of progression-free survival and overall survival, including solitary fibrous tumor, as you can see, including, of course, leiomyosarcoma and a wide variety of different histological subtypes. Probably an important message, trabectedin is active in the majority of histological subtypes of sarcoma. That was also reproduced in a larger phase 4 study of trabectedin in advanced soft tissue sarcoma called the Y image, which basically both demonstrated the activity of this agent in a variety of histological subtypes, but also saw the tolerance of this agent. And again, importantly, progression-free survival, whether it is by investigator assessment using either RECIST or CHOI, was found to be, if not equivalent, actually slightly superior to what was reported previously in the randomized clinical studies. Again, an observation which is not unusual. So the activity reported in different histological subtypes of sarcoma is quite clear in view of the literature. We have lipo, leo, uterine leo, a wide variety of different histological subtypes listed here where demonstrated activity was made on randomized clinical studies. We can see here some example of the quality of response obtained for a variety of different histological subtypes. And probably it's interesting to give here an example of what is so specific with trabectedin, with a presentation of a patient with a dedifferentiated liposarcoma who started actually trabectedin when it was only a number in the context of a phase 2 study conducted by the EORTC, and who received since 2001, we receive up to 65 courses of trabectedin over an 18-year period, stopping, reintroducing, stopping, reintroducing. No other agent in sarcoma is able to provide that as we speak right now. And this is actually exactly for this reason that we tend to propose in the French sarcoma group trabectedin in second-line setting for the majority of patients. Even though some other agents, such as gemcitabine-based regimens, single agent or in combination with DTIC, which we use the most, as compared to gemcitabine docetaxel, which we feel is a bit more toxic, as demonstrated by the British Sarcoma Group study. We use trabectedin because it provides prolonged progression-free survival in the long term, and it's a drug which can be reintroduced later on after the patient is reprogressing months after treatment interruption. What are the latest news around trabectedin? There are many important news. I think one of the important news is probably the LMS-04 study. So you know the literature, and you know that randomized study testing trabectedin versus doxyphosphomide were conducted. I mentioned one in neoadjuvant settings. There is also several first-line settings which actually provided contrasted results. This one was focused on metastatic unresectable leiomyosarcoma, uterine and non-uterine. And the question was to see whether doxorubicin versus doxorubicin trabectedin with maintenance of trabectedin provided different results. Randomized one-to-one doxo versus doxo plus trabectedin and maintenance with trabectedin, stratification on uterine and soft tissue leiomyosarcoma. Patients were included with the aim of improving progression-free survival, and the distribution of patient characteristics across the two arms was well balanced. As you can see on this slide, this is a population of patients where basically the number of cycles received in both arms was quite different, and the nature of treatment given afterwards was also similar. Primary endpoint, progression-free survival, 7.3 versus 13.3 months, hazard ratio close to 0.38. This is an unprecedented improvement in patient outcome obtained with a combination of doxorubicin trabectedin. This is associated with an increased response rate, both in uterine and in non-uterine. This is associated with an improvement in duration of response as well. This is associated with a trend, not significant, but p-value 0.08, as you can see. This is associated with a numerical improvement in overall survival, which was actually never seen in this patient population in previous studies. So for this reason, it went quite clear for us that the treatment with doxorubicin trabectedin could be considered as a standard first-line treatment for leiomyosarcoma on top of doxorubicin DTIC, which, as you know, has never been demonstrated to be superior to doxorubicin in randomized clinical studies in a group of patients. What about side effect profile? Febrile neutropenia, thrombocytopenia, nausea, and vomiting are slightly more frequent in a combination treatment, but still very much acceptable, in particular if you compare that with the doxorubicin ifosfamide classical regimen, which were used for a period of time for this patient population. So PFS by blinded investigator central review, PFS2 overall survival, all gave a similar signal of superiority of the combination treatment, which led to the proposed conclusion that this could be a new standard for the treatment of patients with advanced leiomyosarcoma in the first line, not anymore doxorubicin, but doxorubicin trabectedin. And this is what we are currently doing in the French sarcoma group. All right, so we have seen the activity of trabectedin, the reason why to use it quite early in the patient management, and the interesting observation that leiomyosarcoma cohort could be considered as for the treatment combination very early on. But what about the safety profile of this treatment, including that in frail population, including elderly patients? Trabectedin is associated with a side effect which is quite typical. First, no alopecia is generally observed. We have neutropenia, thrombocytopenia, which is rarely life-threatening. Grade 3 and 4, as we can see on this slide, is relatively limited. We have this strange observation of increased transaminase levels following the administration of trabectedin. But as we have seen over the years, this is actually a side effect which is progressively vanishing as we give more and more courses of trabectedin for reasons which are, by the way, not completely clear. This is non-cumulative. This is not leading to a specific problem. Of course, we still have a side effect profile, which is that of a cytotoxic with hematological toxicity and liver toxicity. We have rare side effects which are life-threatening, but this occurs much less frequently than the classical doxorubicin and ifosfamide regimen. What about elderly patients? Patients aged above 70 were investigated in the large data sets, including the randomized phase 3 3007 trial I was mentioning a few minutes ago. As you can see in this slide, benefit for the elderly for trabectedin also versus DTIC. It's not only feasible, it's also superior in this patient population. And that's something which is quite nicely illustrated by the number of cycles given to elderly patients in the trabectedin group, which is largely superior to that of patients receiving dicarbazine, of course, because the treatment is working. My oldest patient ever treated with trabectedin was a patient aged 92 who received actually up to 12 courses of trabectedin with a very prolonged stable disease for liposarcoma. So that's a drug which can be given for patient in advanced phase and elderly patient. Of course, geriatric assessment is absolutely mandatory, as we always do when we treat patients in advanced age. The large data sets collected in different phase 2 studies are very much in this direction for progression-free survival, overall survival, no difference for patient age above 60 and patient age under 60, no difference for progression-free survival. Of course, this is associated with a side effect profile, which is similar to that of younger patient, but the point is that this is feasible for the routine treatment of the patient. And actually, I think one important observation is this one. We all know that trabectedin can be given in patients with cardiac impairment, in particular those patients who have received previously anthracycline may not receive again anthracycline in the first line setting. And we mentioned already the neoadjuvant use of trabectedin. In this study, focusing on patients unfit to receive standard chemotherapy, the TR1 US study, actually we observed a very significant activity of trabectedin in first line setting in patients who are not able to receive the classical first-line treatment of sarcoma in advanced phase. So in conclusion, reaching the end of my presentation, I would like to share with you how do we use trabectedin in the French sarcoma group. For liposarcoma and leiomyosarcoma, we use it in line 2, and actually for myxoid round cell liposarcoma, which is so sensitive to this specific treatment, we tend also to use it in neoadjuvant setting when required. For the other histological subtypes, including translocation sarcoma, for those with a contraindication to doxorubicin, and for also sarcoma with complex genomics, line 2 is generally recommended. How do we administer trabectedin? Usually, the administration of trabectedin is conducted with conventional hospitalization overnight. We have this solution of giving treatment at home for specific patient groups in this country, and this has been an option that we have been pursuing for some patients for convenience, in particular if patients have difficulty to reach the hospital, and that's something which we have developed with a significant demonstration of the feasibility of this approach. All right, I've reached the last slide, and I will be happy to take questions to share with you that we now have a long-term experience in doxorubicin treatment-resistant patients for trabectedin. We have demonstrated improvement in leiomyosarcoma, liposarcoma, and for translocation sarcoma, as well as in the unselected TSAR population of patients. Toxicity profile is favorable, and sarcoma histotypes of a wide variety of histotypes were demonstrated to be responsive to trabectedin. Maintenance is crucial to provide a long-term outcome of patients. Remember that this is a treatment which is not providing the usual side effects of a long-term of cytotoxic chemotherapy, in particular alopecia and hematological toxicity, which is adapting over the years. We need to adapt. That's a crucial point. Adapt those, schedule along the long-term treatment. Most of the patients after 12, 15, 16 courses are receiving trabectedin every 4 weeks from now on because of convenience. And this is, I think, a main message: adaptation and flexibility to the patient needs. This is what we need. Thank you very much for your attention, and I will be happy to take questions.
Thank you very much, Prof. Play, for excellent presentation. So I will start first with a question. Do you do NGS for all the sarcoma patients, specifically now that we do have the NTARC? So in your practice, you are doing NGS for all the patients. And if we do have patient with NTARC positive patient, how you put trabectedin as a subsequent therapy for these patients?
That's a very good question. We are doing next generation sequencing for the majority of patients in advanced phase for exactly the reason you were mentioning, to find activating mutation which can be actionable, in particular the NTRK fusion protein. Our strategy has been currently the following, because in France, we do not have yet full reimbursement of NTRK inhibitors. So we try to put the patient into the clinical trials of NTRK inhibitors, which is the case for the majority of patients. For those patients who cannot reach clinical studies, we tend to use a classical treatment, which is doxorubicin-based and trabectedin. We have not published that yet, but the data that we have on natural history in advanced phase of NTRK sarcoma shows a very similar outcome as compared to other sarcoma in advanced phase. So logically, this is something which can be developed this way.
Perfect. You presented, thank you very much for sharing your experience regarding the real world data, the French study. And we can see that different types of soft tissue sarcoma were included as well as a retrospective. And so which patient profile and the subtype of sarcoma, you can see that trabectedin is a good, very good medication for this patient, or it can fit for all.
Actually, the second line treatment is after doxorubicin is proposed for LEO and lipo, all translocation sarcoma, and most sarcoma with complex genomics, which is UPS. Those where we tend to follow a different pathway are those currently, as you mentioned, where we identify a target for from the next generation sequencing, and we have some targets which have been identified about MDM2 being one of them. mTOR inhibitors can be proposed for some sarcoma subtypes. In this case, we may use a different treatment, but looking at our current practice, I would say that about 70% of the sarcoma histotypes are proposed for trabectedin. If I put the question the other way, which are the subtype where we do not immediately propose trabectedin? I would say those with a targeted treatment, typically DFSP and some sarcoma with that activating mutation of the kinases.
There is one question online. Is there any comparable study about the efficacy of trabectedin use among the countries using it among Europe, Russia, and South Korea? Can you please?
That's a very important question, because what about the population differences in the use of trabectedin? Actually, we are discussing this exact question recently with a colleague from China, and the short answer is the following. There does not seem to be a difference in the side effect profile in the similar histotypes. Histotype may be different from one country to another. We are finding some evidence of that. What probably should be noted, and you have noticed that the Japanese study was using 1200 micrograms per meter square instead of 1500 microgram per meter square as we use in Europe, with both a better tolerance and much more practicability. And on view of the Japanese experience, we tend to use the Japanese dose for, in particular for frail patients as well. Now, in terms of activity, what we know from countries such as Japan, Korea, to a lesser extent China, is that it looks very, very similar. Limited experience with our colleagues from Russia. I would also say that the major parameter affecting this is probably the flexibility and the capacity to adapt to the patient characteristics. This is what is making a big difference, I guess.
Perfect. You presented as well the study which was presented in ESMO last year regarding the combination with doxorubicin is specific for leiomyosarcoma patient. Very impressive study, and we can see that the dose reduction regarding trabectedin to 1.1 comparable to 1.5. So my question that if I do have a patient who would develop toxicity, thrombocytopenia or hematological, or so we can do dose reduction as a single agent. And the second element, do we maintain after the 6 cycles of doxorubicin with trabectedin? Thank you.
Yeah, this is a very important question. Per protocol, in case of significant toxicity, we decreased both doxorubicin first, then trabectedin. For maintenance, generally the tolerance of the maintenance with single agent trabectedin was quite good. So I would say that the routine strategy that we now use on the basis of the clinical study is to de-escalate doxorubicin first, then trabectedin, and maintain the maintenance dose of trabectedin. Actually, the main toxicity, as you rightly point out, is when we are giving both drugs together.
Yeah, but we can see that you recommended in some studies that the maintenance for the patient, we have to put in consideration that in sarcoma patient, usually they receive as an upfront adramycin followed by gemcitabine, and in some cases. Main point that those patients, they can have myelosuppression, and if you are going for maintenance, this patient can have also toxicity profile. Do we have a cumulative toxicity for trabectedin, specifically the maintenance until disease progression?
That's a very important question. Actually, the reason why we don't use anymore gemcitabine docetaxel is related to this cumulative toxicity. This is a regimen that we have completely replaced now with gem-DTIC, because gem-DTIC is less toxic and as effective, even though there is no formal comparison, looks as effective as gem-docetaxel. For trabectedin, no cumulative toxicity. Actually, yesterday and the day before, there was the yearly days of the French sarcoma group, and a retrospective series was published when one patient, on top of my patient who received 65 courses, one patient received and is still receiving up to 71 courses of trabectedin. There is no other agent, even gemcitabine, actually. Even gemcitabine, where we have given such a long treatment period, I must say. So yes, no cumulative toxicity that we have observed so far.
Perfect. Lastly, I would like to thank you again for excellent presentation and responding to our question. And hopefully we can see you physically next time in Riyadh.
I hope. Thank you.
Yes. Have a good day.
Thank you.
Thank you, my dear. Thank you again for attending this session, and we'll close the session now, and we will have a break of an hour, and then we'll go back with the GI session. Thank you so much for attending and your questions as well. Thank you very much. Assalamu alaikum. Good afternoon, everybody. It's my pleasure to return back to the sessions and going for last but not least, the GI session and my co-chair in this session. Myself, I'm Mervat Mahrouz, medical oncology consultant in Prince Sultan Military Medical City. And I have the pleasure to have Dr. Nashwa Abdulaziz. She is a medical oncology consultant in King Saud University, Riyadh. And also, I will be joined with Dr. Ahmed Mustafa, medical oncology consultant in Khamis Meshet Military Hospital, and Dr. Muhammad Abu Ziada, radiation oncology consultant in the Military Medical City in Riyadh. And we will start the GI session. And it's my pleasure to introduce first speaker, Dr. Shawqi Bazarbashi. Dr. Shawqi Bazarbashi is known for everybody, and he is one of the pillars in GI and the KSA and in the Middle East. He is a medical oncology consultant in King Faisal Hospital, Riyadh, and also he is adjunct professor in Faisal University. He will present one of the late-breaking abstract, which is the dynamic study in last ASCO 2022. Thank you so much, Dr. Shawqi, for joining. Floor is yours. Thank you.
Thank you, Dr. Mervat, and thanks for the organizing committee for allowing me to participate in this symposium. I'm always flattered to be part of your educational symposia. So I have 15 minutes to present the this abstract. This is adjuvant chemotherapy guided by circulating tumor DNA analysis in stage 2 colon cancer. This is a trial that was done in Australia in collaboration with the Johns Hopkins Institute in Maryland. So as a background, the surgery is actually the standard of care for stage 2 colon cancer, and probably would cure about 80% of patients who have stage 2 colon cancer. There is conflicting data on the benefit of adjuvant chemotherapy in stage 2 colon cancer. Accordingly, you see that there is the guidelines for stage 2 is actually to consider adjuvant therapy in patients with high risk. However, unfortunately, the definition of high risk is slightly controversial and different from society to society. And probably not all high risk are the same. So T4 probably does not equal somebody with a less than 12 lymph nodes. And despite this, with those studies that are positive, the survival rate has been modest with less than 5% improvement in the absolute improvement in overall survival in patients with high risk. Having said that, there is actually not a single randomized level 1 evidence to say that adjuvant chemotherapy improves survival in stage 2 high risk patient. However, and based on this, I think we really need to have a more precise prediction for recurrence in stage 2 that will actually limit the adjuvant treatment to really patients who have really high risk and spare those who do not require therapy, the adjuvant chemotherapy. So what about circulating tumor DNA? Now, circulating tumor DNA detects residual disease in many of the solid tumors. And actually, we know that in patients with stage 2, those who have positive circulating DNA following resection, 80% of those patients do recur if they were not treated. And this is very important. So 80% of patients, or around 80% of patients who have positive circulating DNA after resection in stage 2 have recurrence. And accordingly, the benefit up until this abstract, the benefit of doing circulating DNA and using it in the treatment is actually still unknown. The dynamic study was a randomized phase 2 trial. It was designed to demonstrate that
circulating DNA guided approach will actually reduce the use of adjuvant treatment without compromising recurrence risk. So the study included patients who have resected stage 2 disease with R0 resection with performance status of 0 to 2, and those patients were staged 8 weeks after resection and found to have no evidence of metastasis. The patient should have been able to give a tissue for analysis from his primary tumor, and of course they should not have had any previous tumors or cancer. And they were stratified according to the T stage and to the participating center. So there was all those patients underwent circulating tumor DNA at 4 weeks and 7 weeks after resection, and they were randomized in 2-to-1 fashion. The first, or the investigational arm, was circulating tumor DNA guided management, and those patients whom the DNA was positive at 4 weeks and 7 weeks were actually given adjuvant chemotherapy, and this was either oxaliplatin based or fluoropyrimidine based. And those who were circulating DNA negative, they were placed on observation. This is one arm. The standard arm was management according to the standard guidelines, and that is basically patients with high risk disease. They were given adjuvant chemotherapy according to the standard criteria. The endpoints were relapse-free survival at 2 years. There was secondary endpoint, which is the proportion of patients who are receiving chemotherapy, and there are other secondary endpoints like time to recurrence and overall survival. So patients, resected tumors were analyzed for 15 usually recurrent or seen mutation in genes. You could see those genes over there. And so this is done on the primary tumor, and then once those are identified, the plasma of the circulating of the patient is actually analyzed for the presence of any of those 15 genes. And that was done actually in Johns Hopkins. As I mentioned, the primary analysis was intention to treat. So eligible patients were randomized and both had circulating DNA at 4 and 7 weeks. And of course, the analysis was done after a minimum of 2 years for the last patient. The sample size calculation was 450 patients needed with an 80% power and alpha of 0.05. And this was a non-inferiority trial. So it means that the circulating DNA used strategy have to have a recurrence-free survival at 2 years with a lower bound at least 8.5 or less. If it's more than 8.5%, then it does not reach the non-inferiority. So 455 patients were randomized in a 23 institution from Australia between August 15 and August 19. There was 302 patients in the circulating DNA guided management and 153 in the standard management. And as you could see, the intention to treat, most of the patients actually underwent. So 97% received the treatment according to the circulating tumor DNA in that arm, and in the standard arm, 96%. Now, there was 3 patients in the circulating tumor DNA that failed to show any mutation, and accordingly, those were excluded. This is the baseline characteristics, and you can see that there was no significant difference in the baseline characteristics. So you have a majority were ECOG 0, and you have less than 12 nodes, only about 4 to 5%. And the majority also were T3 with 85% in both arms. Now, if you look at the adjuvant treatment delivery in the circulating tumor DNA, 15% receive adjuvant therapy versus in the standard arm, 28%, and that was statistically significant. That was a secondary endpoint, and that was actually achieved. If you look at the type of chemotherapy, even in the circulating tumor DNA, the majority of the patient received oxaliplatin-based therapy, 62%, while that was only 10% in the standard arm. That was also statistically significant. Now, on the other hand, if you look at the time from surgery to start treatment, it was much longer in the circulating tumor DNA, 83 days versus 53 days, and that's expected because of the time taken for the analysis for the circulating tumor DNA. So if you look at the subgroup analysis in the adjuvant treatment delivery, so the numbers of the patient who received or the percentage of the patient who received circulating DNA, you see that more patients with a T4 received chemotherapy in the standard arm as compared in the circulating tumor DNA arm, and more patients also who have poor or grade 3 disease received chemotherapy in the standard arm as compared to circulating tumor DNA. Now, this is the primary endpoint, and this is the recurrence-free survival between the two arms. And you could see the primary endpoint was at the 2 years. The recurrence-free survival was 93.5% in the circulating tumor DNA arm versus 92.4% in the standard arm. That was not significant. If you look actually at the 95% confidence interval for recurrence, you would see that at 2 years, the 95% confidence interval was less than the 8.5%. So that proved non-inferiority of the circulating tumor DNA as compared to the standard treatment, despite a reduction in the number of patients who received adjuvant chemotherapy. Now, if you look also at subgroup analysis for the recurrence-free survival, you would see that in most of the patients who actually had the standard therapy, the recurrence-free survival was lower, especially in patients with T4 disease. Now, if you look at the recurrence-free survival in the circulating tumor DNA, now we're looking at the arm of circulating tumor DNA. The upper curve is those patients who were on observation at 2 years. The recurrence-free survival was 94%. Those patients received no therapy, while those who actually had positive circulating tumor DNA and received chemotherapy, their 2 years recurrence-free survival was 86%. Now, you remember I told you previous studies showed that patients with circulating tumor DNA, 80% of them do recur. Here, the recurrence was the recurrence-free survival was 86.4. Now, if you look at those patients who have high-risk disease clinically for recurrence, and you look at in the circulating tumor DNA, the top curve is those patients who are not high risk for recurrence, average risk for recurrence, and they're circulating DNA negative. If you look at the second curve, the yellow, those which are high risk for recurrence, but they are circulating tumor DNA negative. So despite negative circulating tumor DNA, the clinical risk factors play a role, and those patients do have a lower recurrence-free survival. And their recurrence-free survival is similar to those who had actually high clinical risk for recurrence, positive circulating tumor DNA, and received chemotherapy. Now, if you look at specifically patients with T4 disease, so the top curve are patients with T3 on the right has the blue curve, T3, and negative circulating tumor DNA. The yellow, the lower one, is the patients who actually have T4 but negative circulating tumor DNA. So with negative circulating tumor DNA, T4 continued to be a poor prognostic factor, and the one in the middle is those who have circulating tumor DNA positive T4 and they were treated with chemotherapy. So the summary for the trial is for patients with a stage 2 colon cancer, a circulating tumor DNA guided approach, which is treating only patients with a positive circulating tumor DNA compared to a standard of care. It actually reduced the proportion of patients who are receiving chemotherapy from 28% to 15% and do not compromise the 2 years recurrence-free survival. Patients with a positive circulating tumor DNA after surgery may derive recurrence-free survival benefit from adjuvant chemotherapy. Remember, that was not a randomized trial for those who are positive. They have a favorable 3 years relapse-free survival when treated with adjuvant chemotherapy with 86.4% versus low recurrence-free survival in historical control, less than 20%. And we are waiting for other trials that will provide further information. I think the circulating tumor DNA negative patient have a low recurrence risk without adjuvant therapy. The 3 years relapse-free survival is 92.5%. This is in total. However, those who have high-risk disease, they have slightly lower recurrence-free survival. So with this, I end my presentation and we're happy to answer any question.
Thank you, Dr. Bazarbeshi, for your elegant presentation as usual. We will keep the questions until the end of this session. And now it's my pleasure to introduce one of our eminent speaker, Dr. Ahmed Al-Shahri. Dr. Ahmed is an adult medical oncologist and the head of medical oncology department in National Guard Jeddah. Dr. Ahmed will present a talk about single agent PD-1 blockade as a curative intent treatment in mismatch repair deficiency locally advanced rectal cancer. Welcome, Dr. Ahmed, and mic is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Do you see my screen?
Yes, we see you.
Excellent. Thank you, Mr. Chairman, and I would like to thank also the organizing committee for organizing this successful meeting. And actually, I hope all the best for all the attendees to have enjoyable educational lectures and events. So I have been actually asked to present the data related to use of single agent immunotherapy in locally advanced rectal cancer, of course, MSI high. This is one of the abstracts which actually made a lot of echoes after the ASCO. I'm quite sure that all medical oncologists, they kept receiving a lot of questions from their patients and the social media. Till yesterday, I keep receiving a lot of messages talking about this new agent and how can we apply that in our clinical practice. So I will present these data and we'll have a quick discussion at the end. So we know that rectal cancer, locally advanced rectal cancer, usually is being treated with new adjuvant concurrent chemoradiation followed by surgical resection. Sometimes those patients who achieved complete clinical response after new adjuvant concurrent chemoradiation might be spared like a surgical resection. So they might be kept under close observation or what we call watchful waiting. We know about the mismatch repair deficiency, and we know that almost 5 to 10% of rectal cancers, I would say non-metastatic rectal cancer, are MSI high. With expected number of new diagnoses of rectal cancer of 750,000 globally, we would expect to see somewhere between 40 to 75,000 of MSI high locally advanced rectal cancer. So those are the patients who might be a target for new adjuvant immunotherapy, because we know that those patients who have MSI high rectal cancer are a bit chemorefractory. On the other hand, we have good amount of data to say that MSI high cancers in general, they respond well to checkpoint inhibitors. And this is why those people, the principal investigators of this study, they hypothesize if we have like a non-metastatic or locally advanced rectal cancer, by use of neoadjuvant immunotherapy, we might spare these patients the need for chemotherapy, the need for chemotherapy and radiation, or the need for chemotherapy, radiation, and also surgery if those patients achieved complete clinical response. And this is why they brought this kind of beautiful and elegant design about the use of neoadjuvant dostarlimab, 500 milligram intravenously every 3 weeks for a total of 6 months. So this means 8 subsequent doses of dostarlimab. And during this time, they keep following the patient for response, radiological response, digital rectal exam, pelvic MRI, and also endoscopic visualization of the site of the tumor. So if the patient achieved complete clinical response, the patient will be kept under observation. If the patient still has residual cancer, then the patient will be moved to the second step of management, which is concurrent chemoradiation. And after concurrent chemoradiation, those patients who achieve complete clinical response, they will be followed without need for surgery. However, those who still have residual cancer after concurrent chemoradiation, they will go for surgical resection. So they try to include stage 2 and 3, MMR deficient rectal cancer, and they target for a total of 30 patients. And the primary objective is to have the overall response rate by use of PD-1 blockade with or without chemo radiation, according to the algorithm that I just described. The secondary endpoint or objective would be the safety and tolerability of the immunotherapy in that setting. The overall responses, as I mentioned, have been like judged and monitored by having digital rectal exam, direct visualization by endoscopy, and also pelvic MRI. Other optional assessment tools are the PET scan and multiple biopsies during endoscopy. So all of these are just optional, but the 3, like direct visualization by endoscopy, pelvic MRI, and digital rectal exam, are the most important factors to define response rate, which have been graded into a stable disease, partial response, near complete response, or complete responses. Those are the patients, 18 patients who already been started or randomized. Not randomized, actually, it's not a randomized study, but those patients who have been recruited for this study, we can see that the vast majority were female patients, median age was 54. Most importantly, you can see that most of those patients are locally advanced by definition. 78% they have T3, T4, and 94% they have lymph node positive. Those are the patients usually will be target for neoadjuvant concurrent chemoradiation. And as you can see, the median tumor mutational burden was in the range of 67, which is quite high to predict a benefit to immunotherapy. This is an example of one of the patients who received 6 months of dostarlimab. As you can see, he or she is 38 years old with T4 primary tumor, node positive. He or she being followed for almost 2 years, like 23.8 months. And he or she did achieve complete responses by digital rectal exam, endoscopic, like visualization, and rectal MRI. So the overall that this patient had complete clinical response. This is another patient. This is the endoscopy, as you can see, before starting the dostarlimab therapy. This is after 6 weeks. As you can see, the tumor started to vanish. And this is at 3 months, only halfway through. The tumor has completely disappeared. And this patient has been followed for up to 22 months now. And the patient still sustained a durable response with no evidence of disease recurrence. This is where you see the MRI. There was a rectal wall thickening, and that kind of rectal wall thickening has disappeared completely by 3 months. And this is also the PET scan. You can see there was some activity and uptake at the perirectal region. And now at 3 months exactly, there is no evidence of PET scan uptake or PET avid disease. And this was like maintained to up to 22 months until the last time the patient was assessed. And this is the second patient. As you can see, He or she was 30 years old, T3 primary disease, not positive. The patient was followed for almost 20.5 months with complete responses, as you can see. And the same for the other 14 patients who have been assessed. You can see that there was a 100% clinical response rate, which is really, really kind of impressive data to be presented. And this is with regard to durability of the responses. You can see for some of the patients, they have been followed more than 2 years, and they are still in good, disease-free survival with no evidence of disease recurrence. Some of them are followed for 1.5 years, some of them for 1 year. And there are some of them, they are still followed less than 6 months, but the median duration of follow-up was 6.8 months. And all of those patients, yet they didn't have any evidence of disease recurrence. So the key observations from this study, 100% clinical complete response, no grade 3 or 4 adverse events were observed. No patients have required chemotherapy, radiation, or surgery so far. No disease recurrence observed during the follow-up period. However, longer follow-up is required. And as you can see, the conclusion was really, really impressive here, that these data provide the framework for immunoablative therapies. And this kind of biomarker-driven therapy in early stage disease is becoming a fact. So probably in the near future, we might use MSI as a predictor to use immunotherapy in the neoadjuvant setting. And this is why the data have been simultaneously published at the New England Journal, which indicate that these data are really significant. I'll just go quickly over some discussion about the finding of the study. This is the latest NCCN guidelines for rectal cancer, locally advanced rectal cancer management. As you can see, we still have the standard of care to have total neoadjuvant treatment, to have all chemotherapy radiation before surgery, then surgical resection, or to have concurrent chemoradiation before surgery, followed by adjuvant chemotherapy after surgery. This represents the standard of care for locally advanced rectal cancer, and this has not changed yet, okay? And we know that immunotherapy in the metastatic setting, we have like several trials saying that those who have deficient MMR or MSI high colorectal cancer, they derive benefit from immunotherapy, whether nivolumab, ipilimumab, also dostarlimab have been also FDA approved in MSI high cancers, including colorectal cancer. And we all know that pembrolizumab now represents the standard of care in the first line setting of MSI high colorectal cancer. So no question about the benefit of immunotherapy in MSI high colorectal cancer in the metastatic setting. What about early stage? There have been one small study called the NICHE study using nivolumab or ipilimumab plus nivolumab in the neoadjuvant setting of rectal cancer. Of those who have deficient MMR, 95% they have major pathologic responses, and of those 60% they had pathologic complete response. So this is something we knew from previous studies, that immunotherapy might work in MSI high colorectal cancer, even in the earlier stages other than stage 4. What is interesting about this study, it's the 100% complete responses that we have seen and have been reported from this study, and the durability of this kind of response. Like some of those patients, they still have a complete response for more than 2 years till this point of time. So the key question about these data, are those results clinically meaningful? No question about that. Yes, they are. Because if we adopt this kind of neoadjuvant treatment, this will decrease the long-term toxicities of chemotherapy, pelvic radiation, and surgery, including bowel, urinary, sexual dysfunction, infertility, and permanent stoma. So all of these are huge factors for patients, and it's going to make a big difference for them if we adopt this kind of neoadjuvant immunotherapy management. The only problem that we don't have a good historical controls to tell us whether in those group of patients, whether to adopt neoadjuvant immunotherapy would be as good as the standard of care, which is concurrent chemoradiation at the long run, when we talk about disease-free survival, overall survival, and these factors. Are those results scientifically plausible? Is it possible to have 100% complete responses? Actually, we have some preliminary data that immunotherapy in earlier stages of cancers might work better than metastatic setting. more robust immune responses will be seen and less systemic immunosuppression in early stage cancer as opposed to like advanced cancers. And there have been several reports of using immunotherapy in locally advanced rectal cancer in the neoadjuvant setting. And many of them, they reported higher like rates of complete responses, which is something encouraging as opposed to metastatic colorectal cancer setting. And we know that most of these responses are durable because of the new antigen-specific T cell clones prolongation in the primary tumor and the periphery that increases the tertiary lymphoid structures, which might induce a durable response in these cases if immunotherapy had been used in non-metastatic setting. I mean, like stage 3 and stage 2 rectal cancer. So these data are scientifically plausible. And we'll come to the last and most important question: is this study practice changing? The frank answer, to be honest with you, is not yet. And the reason for that, because we are talking about a small number of patients, so we need a bigger sample. The median duration for those patients is around 6.7 months, so still considered like very short. We need longer kind of duration. The assessment tool that we use here is not standardized among all like cancer centers. So this is a single institution experience. We need to see whether other institutions might adopt the same kind of follow-up for those patients. And of course, we don't have other endpoints like disease-free survival, overall survival at long run. So this is why we have to be careful. Actually, the ideal kind of randomized clinical trial to answer this question is to have like 2-arm study, one of them to go with the standard neoadjuvant concurrent chemoradiation, the other one to go with the exact design of the study to go with neoadjuvant immunotherapy like dostarlimab, as we saw in this study. And by having this kind of head-to-head comparison, we might have the final answer whether this would be the best approach for our patients. Is it easy to conduct a study like this, like randomized, like this kind of design? Actually, it's quite difficult because we are talking about a very rare tumor. The principal investigator here to recruit 18 patients, it took her almost 29 months, like almost more than 2.5 years to recruit 18 patients only. So this is a really challenging kind of area. And most of, like I would say, many oncologists will start to use this kind of approach of protocol to use neoadjuvant immunotherapy. And these patients, even we lack like a high level of evidence. And patients themselves, they will be unwilling actually to be randomized to concurrent chemoradiation if immunotherapy would be an option on the other hand. So all of these are real challenging to have like a real kind of clinical trial to address this kind of study. There have been remaining several questions to answer about this study, about use of combination of immunotherapy or combination immunotherapy plus chemotherapy, and the long-term follow-up of this study would be really interesting to know. The optimal duration of neoadjuvant immunotherapy is 6 months enough, 3 months might be enough, more than 6 months. We don't know the answer to this question, and whether the immunotherapy, the neoadjuvant immunotherapy, as we saw in this study, as it heals the rectal cancer, this will help to prevent other Lynch-related cancers in these patients. All of these are remaining questions to be answered. However, the conclusion, the neoadjuvant dostarlimab for 6 months represent a promising new treatment for patients with stage 2 and 3 MMR-deficient rectal cancer. Larger multi-center clinical trial with longer follow-up and disease-free survival and overall survival endpoints are needed. Identification of predictive biomarker of pathologic complete response will be critical to help to guide the treatment. I would like at the end to thank all members of the Saudi Society of GI Oncology who wrote a very informative statement about this clinical trial, because this trial have been actually announced, and there have been a lot of media talking about it. So a lot of patients, they start to ask about it. The social media, everybody was talking about it. So the Saudi Society of GI Oncology wrote this kind of statement to answer all of the concerns about immediate application of the data of the study. And at the end, I would like to thank everybody and the attendees for their time attending this lecture. Thank you so much.
Thank you, Dr. Ahmed Al-Shehri, for your comprehensive, excellent presentation and your comprehensive analysis as well. And now I will hand the mic to Dr. Ahmed Mustafa to introduce the next speaker.
Assalamu alaikum. Thanks to Ahmed Shehri for your nice, elegant presentation as usual. And it's my pleasure to present our next speaker. Our next speaker is Dr. Kanaan Al-Shamri. Dr. Kanaan is a consultant of adult medical oncology at National Guard Health Affairs, and he's also the director of the MENA NSSN Coordinating Center. His topic today will be regarding the Benito plus Fulfox versus Bev plus Fulfox as the first-line treatment in patients with RAS wild-type metastatic colorectal cancer. This is the results from the phase 3 PADRM trial. Dr. Kanaan, the floor is yours.
Thank you, Dr. Ahmed. And thank you, Dr. Mirvet, Dr. Isam, for your kind invitation. So I was asked to talk about the PADRM phase 3 trial, which was presented very recently in Chicago at the 2022 ASCO annual meeting. So the study basically was an expansion of a perhaps unanswered question, which was retrospectively looked at in the CalGB SWOG 80405, which basically compared cetuximab against Avastin in all comers, and retrospectively reported the benefit of cetuximab in terms of improving survival in left-sided RAS wild-type metastatic colorectal cancer. This was also similarly concluded retrospectively through FIRE3, looking also at cetuximab against Avastin with backbone of chemotherapy, and basically telling us that there is a benefit in left-sided tumors for anti-EGFR monoclonal antibodies. So PADRM was a prospective trial that was attempting to test the superiority of panitumumab against Avastin plus standard chemotherapy in patients with RAS wild-type and left-sided metastatic colorectal cancers. The study design is as follows. There was 1-to-1 randomization of panitumumab against Avastin, and the primary endpoint was looking at left-sided population, overall survival benefits in the left-sided population. So they randomized to 2 groups, the panitumumab and Avastin group. Most patients that were randomized were actually given the drug, and the follow-up time was very appropriate at 61 months. Statistically, or statistical considerations were as follows. The primary endpoint of the study was actually powered to test superiority in the left-sided population, with a p-value of less than 0.04 being significant. And if this overall survival was statistically significant, then a co-secondary primary endpoint is to actually test the overall survival in the overall population. So these are the baseline patient characteristics. If you look at your right-hand side in the overall population, most patients actually had left-sided tumors. There was about a quarter to 1/5 of patients being right-sided or having right-sided tumors. Most patients had widespread metastatic disease, and probably 1/3 of patients had only liver as the only site of metastases. Also, most patients had the primary tumor resected. Now, when we look at the first or the primary endpoint of this study, when we look at the curves, you can see them sort of intersposed over each other. And you can probably see the separation of the curves probably from the 24-month onwards. When we look numerically at the overall survival difference, there is a 3-month advantage favoring panitumumab over Avastin, with a median overall survival of 37.9 months. A hazard ratio was 0.82, so an 18% benefit or reduction in risk of death with a statistically significant p-value. Now, this is only in the left-sided population. Now, when we look at this in the overall population, so remember about 1/4 to 1/5 of those patients were actually right-sided tumors. There was also numerically a benefit of panitumumab, favoring panitumumab, and the advantages were around 5 months. And again, the separation of the curves happened later. The magnitude of benefit was perhaps less with a hazard ratio of 0.84. Now, when we look at the forest plot, looking at subgroup analyses of who would benefit with panitumumab as opposed to Avastin, probably most groups actually benefited from panitumumab. Now, this is only in the left-sided population. In the overall population, again, most of the subgroups actually were benefiting from panitumumab. Now, interestingly, when we look at progression-free survival, when you look at the Kaplan-Meier curves, you can kind of see them over each other without really major differences between the two groups. In the left-sided group, there is no significant numerical difference. The hazard ratio is only 0.98. And in the overall population group, the hazard ratio exceeds 1. And there isn't a significant difference between the two groups. Now, this is interesting. So when we look at response rate, so objective response rate or the degree of shrinkage was actually favoring panitumumab in both the left-sided population group and the overall population group. The left-sided population group, about 80% of those got a partial response / complete response, whereas almost 70% in the Avastin group. So the difference was around 12%. There was also superiority in the overall population, favoring the panitumumab, although the degree of difference was slightly less. In terms of disease control rate, so this is your complete response, partial response, plus stable disease. These were actually quite similar between the two groups. With regards to the duration of response, so how long you maintain this benefit, in the left-sided population, this was preferentially pointing towards a benefit with panitumumab, and the difference was about 2 months. Whereas there wasn't a significant or a huge difference in the overall population. R0 resection rate was also favoring a superiority with panitumumab in both the left-sided population and in the overall population. Now, when we look at depth of response, now let's remember depth of response is the maximal tumor shrinkage. So the maximal tumor shrinkage by a single dimension. So if you look at this swimmer's plot, it is preferentially showing a benefit of panitumumab in both the left-sided population and in the overall population. When we look at the degree of shrinkage, so the depth of response, it was around 60% in the left-sided population and slightly less in the overall population. And on average, the depth of response in the Avastin group was around 43%. In terms of adverse events, probably similar, perhaps more grade 3 events in the panitumumab group. When we look at what adverse events were pointing towards more toxicity in panitumumab, it was mainly driven by the skin toxicity. So if you see in the top here, acne or acne-like dermatitis, and here in the bottom, you can see dry skin. And this is probably what's driving more toxicity in the panitumumab group. In terms of subsequent systemic therapy, there isn't significant differences between the two groups here. So patients who were given an anti-EGFR monoclonal antibody here were given a VEGF inhibitor subsequently, and vice versa. When we look at the right-sided population, when you see the curves, they are almost on top of each other. In fact, numerically, there was a numerical preference favoring Avastin over panitumumab, and the hazard ratio was 1.09. And in terms of your forest plots, most of them were actually favoring Avastin in the right-sided population. Now, remember this association had fewer patients, so 71 and 85, as opposed to almost 300 in the left-sided population, and this association was not statistically significant. So the author's conclusions were as follows. The phase 3 paradigm met its primary endpoint, demonstrating superiority of first-line panitumumab against Avastin in combination with Volvox in the left-sided and in overall metastatic colorectal cancer populations. The difference was around 3 months in the left-sided population. It was slightly higher in the overall population. And exploratory, the right-sided or in the right-sided population, there was a preferential benefit for Avastin. In terms of progression-free survival, these were comparable between the two arms. However, the objective response rate and the R0 resection were higher, favoring panitumumab in both the left-sided and in the overall population group. In terms of safety, no new safety signals were observed. And these results basically support the use of panitumumab as first-line therapy for left-sided RAS wild type and in overall group. Now, the authors also spoke about probably what's exciting, which is multi-omics analysis. So doing ctDNA and tumor signature, so looking at immune markers basically, and doing extended sequencing with tissue RNA. So we are definitely awaiting those results. So these are my conclusions of the phase 3 paradigm. This is definitely the first prospective large randomized controlled trial that actually tested decidedness theory and the difference between an EGFR monoclonal antibody versus a VEGF inhibitor. It was powered to detect differences in the left-sided colon cancer, and it did show superiority of panitumumab in the left-sided tumor. Difference was about 3 months. There was also superiority of panitumumab in the overall population. And I put here, maybe this was driven by the majority being in the left-sided population, because remember, there were 70 odd patients that were right-sided only. Now, in terms of objective response rate, this was better with panitumumab against Avastin in both left-sided and overall population. And Avastin did show superiority in overall survival in the right-sided group. However, the study was not really detected or powered to detect this difference. And by that, I conclude. Thank you very much.
Thank you, Dr. Kanaan, for your nice, elegant presentation. And now I will hand the mic to Dr. Mohammed Abu-Ziada, my colleague, to present the next speaker.
Second, the next presentation about sequential nab-paclitaxel gemcitabine followed by modified Volvox for first-line metastatic pancreatic cancer. The sequence trial will be presented by Dr. Mohammed Al-Qarni. Dr. Mohammed, consultant of medical oncology, King Abdulaziz Medical City, National Guard, Riyadh, and he is also the director of the residency, fellowship, and internship of medical oncology. Welcome, Dr. Mohammed, please.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. And at the beginning, I would like to thank the organizing committee for their kind invitation, and congratulations for the success of this amazing meeting. So my task is to talk about the sequential trial, which is a study that was presented in the last ASCO and addressing the first line in patients with metastatic pancreatic cancer. So although there has been multiple studies that was done over the last 3 decades, and with the slight improvement in the survival of patients with metastatic pancreatic cancer, despite some intensive regimen, still the survival of those patients poor, especially when we're talking about the metastatic setting. And when you look to the options for the first line in patients with metastatic pancreatic cancer, usually we have the options of for fit patient for FOLFIRINOX or nab-paclitaxel in addition to gemcitabine, or for patient with borderline functional status, single agent gemcitabine, and for good number of patients, it will be only supportive care. So the two mainly regimen that's been used in the first line setting, it's just here, I put them for summarizing the data study. It's not meant for comparison. And you can see in those study, they included patient with good performance status for patient with, in the study of the impact, they included some patient with echo performance 2. The overall response rate that we saw in this study was better in the FOLFIRINOX study, 32%, and 23% in patient with nab-paclitaxel. And the median overall survival, the best that has been achieved with FOLFIRINOX is around 11 months compared to 8.5 months in the nab-paclitaxel study. So this is as just some introduction about the topic, and I already summarized this. So this is the study that was presented in last ASCO, and it's actually studied the sequential use of nab-paclitaxel in addition to gemcitabine, followed by modified FOLFOX in the first line setting. So the aim or the purpose of the study is to increase the efficacy of the treatment in all patients with metastatic pancreatic cancer subtypes. The rationale that they use in this study is looking to the subtype of patient with pancreatic cancer, although we are not relying on this much when it comes to clinical use of the first line. So they think the basal cell type respond better to nab-paclitaxel plus gemcitabine, and the classical subtype has a better response to FOLFIRINOX. And nab-paclitaxel has been shown to increase the desmoplastic stromal depletion, and it might facilitate the access of anti-cancer drug in patients with pancreatic ductal adenocarcinoma. And it was published in a phase 1 trial that it's a safe approach with some clinical activity. So this is a phase 2 study that included more patients addressing the question about this regimen in the first line setting. So in this study, they included 157 patients, and they were randomized into either gemcitabine, nab-paclitaxel, the IMPACT protocol, or the gemcitabine in addition to nab-paclitaxel, day 1, 8, and 15, every 4 weeks. Then this will be followed by modified FOLFOX at day 29. So they repeat this every 6 weeks. And they continue the treatment until there is an acceptable toxicity or a withdrawal of the informed consent. The primary endpoint of the study was to increase the efficacy in terms of 12-month overall survival. And there are multiple secondaries endpoint, including the overall response rate, time to progression, and progression-free survival. So by using the IMPACT and PRODIGE study for the first line setting, the hypothesis that they need 78 patients in each group in order to increase the efficacy of the drug and the survival of 1 year from 35% to 50%. And in this study, they have 30 months of inclusion and 24 months of follow-up. This is the consort flow diagram of the patient. At the end, they have 76 patients who included in the safety analysis because 3 of the 2 patients were not treated. However, they include 79 patients in the intention to treat analysis. If you look to the baseline characteristics, the median age around 65, they included very well selected patient, ECOG 0 and 1, and they have about 2/3 of patients, they have more than 3 metastatic site. And this was balanced between the 2 groups. When it comes to the first analysis they do was the safety analysis. And for any event, you can see about 2/3 of patients that receive the experimental arm, they have a side effect compared to 57% on the standard arm. For serious event, it was 48% in the experimental arm compared to 43% in the IMPACT group. Now, coming to the objective response rates, if you look to the disease control rate, it's about, they achieve it in about 80% of patients, and the response rate, it's not really different much from the FOLFIRINOX study, about 39%. If you look to the time to progression, it was in favor of the experimental arm, although this is a secondary endpoint. It was a 9.3 versus 5.3 in the standard arm. And if you look to the progression-free survival, numerically was in favor of the experimental arm. Now, if you look to the overall survival of the patient included in the study, you can see the median overall survival for patient in the experimental arm was 13.2 compared to 9.7 in the standard arm. So this is the primary endpoint of the study. It was at least met by the analysis. 12-month overall survival was 55%, and they aim for 50% in the statistical analysis. Now, this more dissection of the treatment exposure, patient on experimental arm, they usually stay longer on treatment. Number of cycles was more in patient in the experimental arm. The number of full regimen cycles was less in the experimental arm. And if you look down to the interruption of with at least one drug, about 80% of patients in the experimental arm, they have transient interruption compared to 64% on the impact protocol. This is also to show some of the treatment exposure analysis for nab-paclitaxel and gemcitabine. There has been delayed in more than one cycle in about half of patients on nab-paclitaxel and the same on the impact group. The dose reduction for more than one cycle happened in almost 2/3 of patients on the experimental arm, and permanent stopping of the nab-paclitaxel happened in 6.6% in the experimental arm versus 12% in patients with the impact group. These also the subsequent lines that the patient received in both arms. The nab-paclitaxel group, they have second and third, and some patients they receive fourth line. And if you look to the nab-paclitaxel, in addition to modified FOLFOX, also there are some patients who receive subsequent line that was either liposomal irinotecan or oxaliplatin based or oral capecitabine. So in such a study, I think the quality of life is very important. However, the analysis that they did is still preliminary. However, what they can comment for now is there was no difference in the physical, emotional, or social functioning, nausea, vomiting, pain, or other symptoms, and including financial toxicity. However, one of the most important toxicity, which is neuropathy, has not been analyzed yet, and we are waiting for having the final analysis for the neuropathy. So the conclusion of the author of the study that the sequence trials show manageable safety profile with a higher amount of all grade neurological events, and including more grade 3 or higher hematological toxicity. The sequence schedule efficacy result for untreated pancreatic cancer support the clinical activity of this experimental regimen. And the significant the efficacy rate improvement was observed, although when compared to other recently studies, it represents just a step forward and a solid and promising alternative for the benefit of patients with metastatic pancreatic cancer. Now, when you look to the comparison between all the two studies that I shown at the beginning, so you can see all the studies included. The median age was around 65. We have to say that the PRODIGE and the IMPACT are phase 3 study. This is a phase 2 study. The super selected patient on this study also is something to consider. If you look to the overall response rate, it's almost similar to that we have seen in the patient received FOLFIRINOX. The median progression-free survival, if you look to the FOLFIRINOX study, was 6.4. In this study, it's about 8 months. And the median overall survival was 11.1 month in the FOLFIRINOX study compared to 13.2 months in this protocol. However, as I mentioned, this is a phase 2 study. Still, we are waiting for more analysis of the quality of life analysis, which is very important in this group of patient and with such intensive regimen. And by this, I conclude. Thank you very much.
Abstract. And now it's my pleasure to introduce the next speaker, Dr. Ashwaq Al-Alayan. Dr. Ashwaq Al-Alayan is an adult medical oncologist at the National Guard, Riyadh. Dr. Ashwaq is well known to all of us with her experience in GIT management, GIT cancer management, and especially hepatocellular carcinoma. She will present to us Lymphadenectomy combined with the transarterial chemoembolization as the first-line treatment for advanced hepatocellular carcinoma. It's a phase 3 multi-center randomized controlled trial. Please, Dr. Ashwaq.
Thank you. Thank you for the nice introduction, and thank you for Mervat and Dr. Assam for the invitation. I was given the task to talk about this clinical trial, which I think it's a part of important topic is going to come in the treatment of HCC. As we all know, we're now moving more toward combination therapy rather than only systemic therapy in a patient with advanced HCC. So this is looking at a combination of lenvatinib plus TACE versus lenvatinib alone and first-line therapy in patient with advanced HCC. So we know HCC is the 90% of primary liver disease, and globally it's rising, and it's around 50% of cases occur in China because of the high incidence of hepatitis B. And it's ranked number 2 in terms of mortality related to malignancy. So we know like most of our patients are coming in advance, which is stage C. And again, if we look at the number of patients in North America, around 40% with stage C and 50% in Europe, 55% in China. Again, if we combine this with also stage B, which is most of stage B will be moved to stage B if they were not treated in a proper way. So we know that we have a lot of advances in terms of management of patients with HCC, in terms of first-line therapy and second-line therapy. And we know that lenvatinib is one of the drugs that will be improved in the first line with improvement progression-free survival above sorafenib. We know the data from lenvatinib that in overall survival, we have no superiority advantage. We know that only progression-free survival and time to progress. In terms of overall response rate, we know lenvatinib works well in terms of overall response rate compared with sorafenib. So we know that they try to find a strategy, and we know when we give the patient TACE, we reduce the tumor burden in a short time. Post-treatment, they will have a new vessel formation that might lead to metastatic and recurrence, which can be inhibited by using systemic therapy like lenvatinib. So that's the idea. And we look at the sequential therapy compared sorafenib and lenvatinib. Sorafenib did not show any much of benefit in sequential therapy in patients who received TACE. If you look at on the right side, TACE, sequential therapy with TACE and lenvatinib, they have a ratio of 0.4. So it does work on combination with lenvatinib. So it's a phase 3 multicentric, compare the efficacy of lenvatinib plus TACE versus lenvatinib monotherapy first line setting with advanced HCC. So the basic characteristic or the assessment of the patient should be advanced primary HCC without previous treatment. So naive treatment, naive patient with measurable disease by modified RECIST criteria. They look at measurable disease, that single lesion should be less than 10 cm or the number of multiple lesions should be less than 10 cm and tumor burden less than 50% of the liver. And tried score of A, good performance status, and good liver and kidney function. And they look at also other certification, which is performance status, tumor thrombosis, and also body weight, which is very important for lenvatinib. So TACE lenvatinib, TACE will be given in day 1. Lenvatinib will be paired based on the weight, either 8 or 12. And again, the other arm would be lenvatinib single agent, looking at primary endpoint, overall survival, secondary progression-free survival, time to progress, and overall response rate and quality of life. And if you look in the top, this is the patient. They will be screened within 14 days. They will start the treatment of monotherapy of lenvatinib. Patient will receive lenvatinib 3 days. TACE will start on day 1, and after that, patient will receive lenvatinib. So the subsequent TACE will be on demand, which is depend on the assessment by radiology if the patient will need the re-TACE. So the inclusion criteria, age from 18 to 75, patient with primary HCC, as I said, measurable disease, good performance, and also good kidney function and liver function, and also blood. They exclude patient with infiltrative lesion, which is sometimes hard to taste, pre-mets, patient with history of hepatic encephalopathy, very bad ascites or esophageal varices, or any contraindication for TACE, or patient have allergic to the contrast media, pregnant, co-infection with HIV or syphilis, patient with other malignancy, and patient who received liver transplant, and also with other dysfunction with their cardiac or kidney and other serious infection. So they were looking at the median overall survival for advanced HCC, and it's assumed like 10 months. We expect it to be 15 months. They look for hazard ratio of 0.67. Sample size was 336 patients on randomization, and they some of the patients were was not randomized to the study because of contraindication, so it was 179 patients. So for each, we have 338 patients. So they are around 170 in each arm. Some of patients, there were lost follow-up or have progression or adverse events. So these patients were excluded upon follow-up. If you look at the basic characteristic between the two arms, for age are equal, or for gender, body weight, but most of the patients, they were hepatitis B, around 87%. And again, if you look at the multiple lesion, they're more than 80%, they have multiple lesion. More than 5 cm is exceeding 70% on both arms. Patient having microvascular invasion or portal vein invasion was around 71%, also in both arms. 50% where they have extrahepatic spread or not. Alpha fetoprotein were very much equal, whether it is higher or lower than 400. Here, if you look at the other column, which is the modified RECIST, that will make it easy. If you look at the complete response was 2.5 to the combination between TACE and lenvatinib compared to 0.5. Partial response was almost double for the combination of lenvatinib TACE compared with lenvatinib alone. Stable disease very much was like equal, was 48%, is a bit higher in lenvatinib group. Progression disease was higher on lenvatinib group. Objective response was higher on the combination group, which is expected, more than 50%. And disease control rate was around 90% in the combination group compared to 73%. If you look at here, the median overall survival and also the survival without disease progression, both hazard ratio was 0.45. If you look at the number, it was the median overall survival 17.8 months for the combination compared to 11.5 to lenvatinib alone. If you look at the subgroup analysis, again, it's all favoring the combination, whether the tumor size, portal vein invasion, extrahepatic disease, and also the progression-free survival similar, all favoring the combination group. This is looking at the portal vein and treatment allocation. It was independent risk assessment, or it was independent risk assessment for the patient, which is the age and portal vein thrombosis. For these patients, if you look at the p-value was significant for age and also for the portal vein thrombosis. Looking at the adverse effect again, if you look at both group, if you concentrate on the grade 3 and 4, was very modest. But if you look at the lenvatinib TACE, they have more patients, they have increase on LFTs and bilirubin. This is looking at the subsequent therapy. I think we have higher number of patients. They went to resection, which is that indicate more of local disease or local control. TACE was very much equal for these patients, and also targeted disease or systemic therapy or even immunotherapy in these patients. Radiation very much the same. So they are looking for the administration of lenvatinib. Again, if you look at the median between the both group, again, more inpatient on the TACE arm, and the daily dose was very much similar between the combination and single. Reduction was higher on the patient who received TACE, and also stopping the treatment was higher on the combination group. This is looking also at TACE administration. You will find more patients on this treatment receive the conventional TACE rather than the DC beads. I'm not really sure, but if you look at disease progression, which is something was not expected, was higher on the patient who received DC beads. So in conclusion, the combination is safe. I think this is the most important. Again, it is safe and effective in terms of overall response rate, PFS, and also the response rate. Patient lenvatinib plus TACE may be present a potential treatment option. I think not for all the patients. I think there will be subcategory of the patient. Again, we don't have enough customization for these patients who will be a candidate for this combination. So by this, I'll thank you.
Thank you very much, Dr. Ashwar, for excellent presentation. And going to the last presentation by Professor Gerald Brager. Professor Gerald Brager, he is Associate Professor in Medical University of Vienna, and he is Medical Oncology Consultant in Comprehensive Cancer Center in Vienna as well. Professor Gerald, he will discuss the top abstracts of the GI session. I think we were a little bit saved by some of the speakers, and thank you so much for joining us. The floor is yours. Thank you.
Hello, I hope you can hear me. I want to say thank you to the organizers that I have the opportunity here to contribute to this great conference. As you might know, concomitantly, there is the World Conference on GI Cancer in Barcelona, and that's one of the reasons why I'm here online and I cannot be here face to face. However, it's my big pleasure and honor that I discuss now the presented abstracts and then try to put this in context into our daily clinical practice. So the abstracts that we discussed today is circulating tumor DNA, especially in the adjuvant setting, the neoadjuvant treatment in MSI high or mismatch repair deficient rectal cancer, the best treatment strategy in RAS wild-type metastatic colorectal cancer. And then we switch the solid tumor type and go to pancreatic cancer with the question, how can we optimize the prognosis of our patients with metastatic pancreatic cancer? And in the end, as you have just heard the abstract, about local ablative treatment in advanced HCC. Let me first start with the ctDNA and the role of ctDNA in the adjuvant setting of colorectal cancer. You have seen the abstract of the dynamic study, which had the aim in the stage 2 colon cancer, where there is no standard recommendation of an adjuvant treatment, that you stratify the treatment according to the ctDNA, whether it can be detected. Then you send the patient for adjuvant treatment, or those who have negative, you do not torture your patients with potentially toxic adjuvant treatment. And this was randomized 2-to-1 to a standard management in stage 2 patients, with the primary endpoint of relapse-free survival at 2 years. You have seen that with the strategy of only treating those patients with a positive ctDNA detection in the experimental arm, you could find quite comparable disease-free survival intervals, so showing a non-inferiority, which was confirmed by this study. So after 2 years, the rate was quite comparable in the difference in 2 years relapse-free survival plus 1.1%, but this was within the confidence interval. So this strategy clearly demonstrates that it might make sense to just treat patients, at least in stage 2, with positive ctDNA and do not treat patients who has a negative ctDNA level. This is not the only study. There is an emerging evidence that stratifying patients with ctDNA levels in the adjuvant setting might make sense. Recently at the ASCO GI meeting in January this year, we have seen data from the Japan Circulate study trial, which was also an adjuvant study, but not only limited to rectal, but also colon and anal carcinoma, but adenocarcinoma. The study clearly demonstrated that ctDNA is on the one hand prognostic. As you can see, those patients with positive ctDNA level at baseline before you started treatment had the worst prognosis, especially if adjuvant treatment did not change the level. However, it was also very good to see that those patients who were in the beginning positive, and you could convert those patients to negative ctDNA level due to adjuvant treatment, had a quite comparable good prognosis when compared to patients who had in the beginning already no ctDNA detected. So this data demonstrates that the conversion of a positive state to negative might indeed make sense in terms of disease-free survival. This was true for every stage. So high-risk stage 2, positive ctDNA patient had a benefit from adjuvant treatment. The same was true in stage 3, but even also in stage 4, those patients with positive ctDNA level treated with an adjuvant treatment had significant improvement of their outcome with the readout of disease-free survival. So is there a benefit of ctDNA detection yet? I would say, yeah, we have increasing evidence for a clinical benefit of ctDNA. It's prognostic, but I think it's very important that it seems also to be predictive for the adjuvant treatment. So far, however, ctDNA detection is no standard yet for any types of GI cancer. We need to have standardization. When do we measure ctDNA? What is the method? What should be the cutoff, the techniques we are using to have comparable data, and we need this then incorporated into guidelines. The second abstract I want to discuss is the neoadjuvant treatment in MSI-high mismatch repair deficient rectal cancer. We were very much impressed from this late-breaking abstract at ASCO meeting 2022, where Andreas Surka did demonstrate the role of an PD-1 antibody in patients with rectal cancer, locally advanced rectal cancer, treated with the antibody and showing in all the patients a complete clinical remission. And this was very impressive. The number of patients was limited to 14. Then in the full publication, it was 16 patients. So low patients numbers, but very consistent data that after 6 months of treatment with dostarlimab, a clinical complete remission could be achieved without radiotherapy, without surgery. You could achieve this treatment aim. In fact, the duration of the response was much longer than the 6 months of treatment. In many of these patients, there were an ongoing treatment at time of analysis. So the duration of response seemed to be really very prolonged and sustained, with a median follow-up of so far just 6.8 months. However, is this new? I would say no, it's not new, because already in the year 2019, we have seen first data from the so-called niche trial. It's a European trial from the Netherlands showing quite comparable data. In this niche trial, it was also a neoadjuvant trial of stage 2 and stage 3 patients treated with nivolumab and ipilimumab. And in their trial, they had mismatch repair proficient, but also mismatch repair deficient colon cancer patients. At this year ASCO meeting, we did see an update of their data. And it's very consistent to the previous shown abstract that patients with mismatch repair deficiency, they achieved a pathological tumor regression. You cannot indeed compare these two studies because a tumor surgery was also already done 6 weeks after initiation of immunotherapy, while in the dostarlimab study, the treatment was 6 months, so 6 weeks versus 6 months. But the benefit of the niche study was tumors were resected, and what you got in the analysis was a pathological response of the tumors, treated only 6 weeks with immunotherapy. So it seems like it's feasible to use checkpoint inhibitors in mismatch repair deficient MSI high patients. This has been already demonstrated at the ESMO meeting in 2019, but now we have seen, especially in a tumor type like rectal cancer, where surgery is associated with a lot of morbidity in the patients when you remove the rectal cancer. And so you can likely prevent surgery and go for organ preservation with a complete clinical response when you treat those patients with an immunotherapy. However, it's the limitation of MSI high or mismatch repair deficient patients. However, there is also for the mismatch repair proficient MSS patient new treatment approaches for organ preservation. This was demonstrated at the Star Trek phase 2 trial at this year's ASCO meeting. Those patients who achieved the clinical response, almost clinical complete response, organ preservation at 12 months was possible in almost 60% of the patients. So organ preservation as the aim of this approach seems to be feasible in 60% of the patients. This is very much consistent of the data we have seen from the OPERA trial. The OPERA trial, which was presented already a year ago at the ASCO meeting, had a readout of the near complete clinical response and complete clinical response when you had patients treated either with radiotherapy followed by consolidation chemotherapy, or vice versa, where you had induction chemo followed by radiotherapy. The aim was, again, also a watchful waiting, so organ preservation strategy, at least for those patients who achieved a complete clinical response or near complete clinical response. And the data very promising for those with organ preservation. Was very likely after 3 years to have organ preservation in 78% for those patients with a complete clinical response, but still for 45% with the near complete clinical response. This was also reflected in disease-free survival, local recurrence, and metastasis-free survival. So good response is the aim. However, in this study, the follow-up was, in my opinion, only a little bit insufficient because it was only clinical follow-up, and they did not include MRI testing, which I would recommend if you go for organ preservation strategy, because you have to tightly follow up your patients with endoscopy, with MRI scans, and then of course a standard CT scan to have an early detection of a local relapse. And if there is a local relapse and you detect it early, you might go for it with a minimal invasive procedure. So what could we learn from the recent data in rectal cancer? Well, the MSI high mismatch repair deficient, the neoadjuvant treatment with checkpoint inhibitors seems to be feasible. The moment it's experimental, but you should discuss it with your patient already now, because you might spare aggressive radiotherapy and surgery in these patients when you can potentially cure those patients with checkpoint inhibitors. The total neoadjuvant treatment is for the others, for the MSS patients, especially for the aggressive tumor types, or for those where watchful waiting and organ preservation is the treatment aim. For early stage, you should go for standard radio or chemoradiotherapy or front-up resection if it's really in very early stage. And then I think watchful waiting is key, and you should include endoscopy very tightly every 2 to 3 months, MRI scans, and a CT scan twice a year for the first 3 years. Let's go to the metastatic setting. And we have learned the best treatment strategy for those where the tumors are considered to be RAS wild type. If we look on the treatment guidelines, you can see that this is already considered those where you want to have a cytoreduction, the RAS wild type patients. Only approximately 50% of or less of all the patients are considered to be RAS and BRAF wild type. But at the ASCO meeting, there were 5 big phase 2 or phase 3 prospective randomized trials presented, only focusing on this subtype of colorectal cancer. We have learned within the last years that in the RAS wild type patients, you should start with anti-EGF receptor antibody, which is in favor, especially with the left-sided primary tumor, leading to a superiority in the overall survival. Very similar, the PADRM study, which was performed in Japan, had a quite similar approach for the RAS wild type metastatic colorectal cancer patient. In first line, they were using FOLFOX as a backbone and were comparing bevacizumab versus an anti-EGF receptor antibody, namely panitumumab. It was good to see that the data we achieved from FIRE3 and CALGB trial were confirmed in the Japanese population with a superiority for the left-sided primary patients with panitumumab plus FOLFOX with an hazard ratio of 0.82. Is it new? No, it's not. Is it practice changing? No, it should not be, because we already do it like that, but it is confirming to see the PADRM data. However, on the very same meeting, also the strategic trial was presented, which was also an open label phase 3 study in the RAS and BRAF wild type population in first-line treatment of metastatic colorectal cancer. This was one of the first sequential treatment designs. In the arm A for the RAS wild type, they were going for FOLFIRI plus cetuximab and changed upon progression. In the other arm, they started with an Optimox plus bevacizumab, had the second line with FOLFIRI plus bevacizumab, and had the anti-EGF receptor antibody in third line. So what did they compare? 2 lines of treatment versus 3 lines of treatment, and the primary endpoint was duration of disease control. So I would assume that when you plan to do 3 lines, it might be superior when compared to 2 lines. However, you start with cetuximab in the RAS wild type first in arm A. And arm A was the winner in terms of the overall survival with a superiority 37.8 months, which I think the numbers are exciting, almost 38 months compared to arm B. However, this was not statistically significant. I would say a clear trend in favor to the 2 lines of treatment design when you start with anti-EGFR. So the trend favors the 2 lines of treatment with anti-EGFR first. Furthermore, this is confirmed by the secondary endpoint with cetuximab first with a higher response rate, 82 versus 69% in favor of the anti-EGF receptor antibody in first line. Let me now switch tumor type and let's go to metastatic pancreatic cancer. Can we optimize the prognosis in this aggressive disease? It was good to see that we have data now from a Spanish cooperative group design where they have used sequential nab-paclitaxel gemcitabine, which is for sure a #1 first-line treatment option, but then followed by FOLFOX, and they compared it in the sequence trial to regimen just with nab-paclitaxel gemcitabine. The regimen was a little bit more complicated because after nab-paclitaxel gemcitabine, which was used in the standard regimen day 1, 8, and 15, they had the FOLFOX and day 29 in a 6-week cycle, while in the standard arm, it was the conventional nab-paclitaxel gemcitabine regimen every 4 weeks. It was treated until progression of the disease. So let me a little bit show you what are the treatment recommendation NCCN, and this will be the recommendation of the ESMO guidelines, which will be published this summer. Non-published yet, but I can show you this illustration as I'm one author of the guidelines. So nab-paclitaxel gemcitabine is number one recommendation for treatment regimen in first line, which is in line with FOLFIRINOX as also the alternative recommendation for those patients. And then if you start with nab-paclitaxel gemcitabine, you would go to second line upon progression, either to liposomal irinotecan 5-FU or to an oxaliplatin-containing regimen. FOLFIRINOX was not the topic of the sequence trial, but if you would start with this, gemcitabine would be a second-line option. So in the sequence trial, they combined nab-paclitaxel gemcitabine with a FOLFOX regimen. You have to be aware that the FOLFOX regimen was tested in second line, the so-called PANCREOX trial, but the PANCREOX trial was a negative trial. Let's put the focus in the second line trial. In the PANCREOX trial design, which was a phase 3 trial, FOLFOX was compared to infusional 5-FU alone. All patients were pre-treated with gemcitabine in first line, and surprisingly, the combination of 5-FU with oxaliplatin was significantly inferior to 5-FU alone, with 6 versus 9 months. So there was an inferiority, and there was also no signal of an increased activity when you look at progression-free survival between these two treatment arms. So clear negative trial was the FOLFOX regimen, but still in the sequence trial, they considered this regimen and incorporated into the first line. There were positive trials, however, in second line with oxaliplatin, the OFF regimen, which is more complicated, more tricky, with every other week oxaliplatin, every week infusional 5-FU, and then 2 weeks break. This was significantly superior when compared to 5-FU alone. And this trial from South Korea, again, oxaliplatin plus S1 did not show a superiority. So in summary, oxaliplatin in second line in gemcitabine pre-treated patient resulted in conflicting data. So no clear signal whether oxaliplatin in second line does make sense. In the sequence trial, however, they incorporated the FOLFOX regimen, and this was superior in the treatment design. So progression-free survival was 7.9 versus 5.2 months with a hazard ratio of 0.5, which was statistically significant in favor of the more tumor agent considering experimental arm. Overall survival was also statistically significant, superior 13 versus 9.7 months. However, if you look a little bit more into detail, what was given after nab-paclitaxel gemcitabine in the standard arm treatment, we can see that only 50% did see more than these two agents. And so there were less aggressive treatment in the standard arm when we compared it with experimental arm, where 100% had oxaliplatin in the treatment regimen. So I don't know whether we indeed can compare this trial regimen if not every patient, only every other patient did see a second line treatment in the standard arm. In the end, some words about the impact of the local ablative treatment in advanced ACC patients. This trial considered, and this is the difference to other TACE trials, patients with the advanced stage. So according to the BCLC guidelines staging system, this was an advanced stage C patients, where the treatment recommendation is systemic treatment. We know that for those patients, we can expect overall survival of 18 months plus if we treat them with atezolizumab and bevacizumab. This is illustrated here, where for a long time we were using sorafenib as a standard treatment with median overall survival of a little bit above 10 months. With lenvatinib, it went a bit up, but with atezo-bev, we can expect 18 months plus if we start treatment with this regimen. So we know that immune checkpoint inhibitors in the treatment of HCC are either already approved and in clinical use or in clinical trial. Several approaches are used, combination of checkpoint inhibitors plus VEGF inhibitors like bevacizumab. There are trials where you combine checkpoint inhibitors with TKIs like cabozantinib or lenvatinib. And then there are trials where you combine checkpoint inhibitors with each other like ipi/nivo or tremelimumab durvalumab. The launch trial considered the very same patient population as I mentioned. So patients who should be treated systemically, and indeed also in the launch trial, both arms were treated with lenvatinib, the TKI, and not the standard of care with what we would use now with atezo-bev or checkpoint inhibitor combinations. However, they were adding TACE in the experimental arm in a one-to-one randomization design with the primary endpoint of overall survival. So you have seen the data from the previous speaker that the combination of TACE to lenvatinib was superior to lenvatinib. However, lenvatinib arm performed worse than we would expect it. And as I mentioned before, lenvatinib is not the first-line standard anymore. So it's questionable whether we can go for the combination of lenvatinib with TACE, as we can expect median overall survival with atezo-bev without the TACE treatment in this patient population. So how can we interpret the data? I think there's no change in the standard of care because standard of care is atezo-bev right now. In the trial, there were heterogeneous patient population, which in addition limits the interpretation. There were younger patients with Hep B. Lenvatinib underperformed versus expected. There were higher rate of resection in the combo arms, and we think it's more patient selection. Shortly mentioned that we have other options than atezo-bev. If atezo-bev is not an option right now, we have the data from the Himalaya study where the so-called STRIDE protocol was used, so tremelimumab plus durvalumab. Be aware that in this Himalaya trial, portal vein thrombosis patients were excluded. So it was again a pre-selected patient population with potentially lower risk of bleeding anyway, with a better prognosis of the patients. And there were also no endoscopy as a prerequisite when you compare it to the atezo-bev trial. We know that for the progression-free survival, the STRIDE protocol had 3.78 versus 3.6 versus 4 months, so no difference. But the overall survival did. There was a slight but clinically significant benefit with 16.4 versus 13.8 months for the STRIDE protocol when compared to sorafenib. However, there was a tail in the curve. So there is indeed the patient population which we would consider as long-term survivors. And I think it's important that we can identify those patients. The overall survival is a secondary endpoint for durvalumab versus sorafenib. I think durvalumab alone was also considered or can be considered as safe for Child-Pugh B7 scoring patients. And this we should keep in mind might be an option for those patients with not a very good liver function. So when we do a crossover comparison of this trial, the IMbrave 150 trial did indeed reveal a median overall survival of 19.2 months. It's a little bit hard to compare because it's a slightly different patient population in the Himalaya trial, especially when it comes to hepatitis B positive patients, but it did reach numbers of 16.4 months. And then we have other trials which did not perform so well, like cabozantinib, atezolizumab. So what's the conclusion of this abstract? Atezo-bev remains in the prime position. The STRIDE was borderline negative. No, it was indeed, it was positive. But it, I think, in my opinion, a distant choice. there was a patient population. They excluded patients with portal vein thrombosis for the Himalaya trial. There was a less risk of variceal bleeding, but sorafenib did well versus the others. And then you might have the single agent durvalumab for the child B7 plus patients if you want to treat them. However, because of the tail of the curve in the Kaplan-Meier biomarkers to identify those patients who do have a long-term benefit that desperately needed. So this is how we do it in our center. If there is the patients with no with a good, let's say, organ function, the primary treatment aim is to go for a TSU bath. For those who do have a contraindication against checkpoint inhibitors, you go for TKIs in first line. And those who do have a risk of severe bleeding, we would start with the STRIDE regimen. You might have those with child B7 plus patients where you might consider still durvalumab as a treatment. So thank you very much for your attention.
Thank you very much, Prof. Gerald. Excellent discussion. I'm inviting our speakers to join us here, and we'll go for a voting so we can just see how is the attending look at the data as well. So the first question, did you miss a physical international and national meeting? Yes, no. Can you please vote? This is the question for the attendees. The floor can also scan the barcode. So we do have 5K, and also we have around 2,000 on YouTube. And the YouTube cannot vote, just only on the Zoom or on the floor. So 67% they missed the physical and 33 said no. Okay. And the second question. So dynamic study is phase 2 study. However, is it changing practice in colon cancer as an insight about stage 2 disease? Agree, disagree, I will wait for phase 3 study. Can you please vote? You were very convincing, Dr. Shauki, and agreed about 73%, disagree about 4%, and only quarter, about 23%, I will wait for phase 3 study. So how do you comment? And I will ask your comment as well, Prof. Gerald.
Well, unfortunately, I'll be with those who disagree because there is no standard, although the dynamic is it is a phase 3 trial.
Okay, so you will disagree or you will wait for phase 3 study?
It is a phase 3 trial,
Okay.
but the point is there has been no standardization of the circulating tumor DNA. Until this is done and confirmed and becomes commercially available, I don't think we'll be able to use the dynamic data in daily practice.
Okay, what do you think, Gerald?
Yeah, I totally agree. So I would wait for more data. There are increasing evidence, however, we are not there yet. So many open questions. When should you measure? How many days or weeks after surgery? What do you measure? What is the threshold? But I think in the near future, within the next 2 or 3, probably 4 years, we will have this into our clinical practice. I hope so. It's a good tool, but we are not there yet.
Okay, so putting the facts that the study gave us about 15% of the patient can omit for them the chemotherapy safely. And in the main point also that it was clear that the patient was ctDNA positive, and this is not the only study. So guys, you are still waiting. Do you have any other comment from the panel regarding the waiting part?
Excuse me.
Yeah, please.
Also, I have a comment regarding the dynamic study. Of course, it's a promising one using circulating DNA to follow our patient as a predictive or prognostic from the previous studies, but still it has like the question of addressing like negative results and positive, false negative and false positive results not addressed in the study. False negative for the patients who are non-shedding the ctDNA. No comment. It represents about 10% of the colorectal cancer patients, and also patients with metastasis in the lymph node, peritoneum, or lung, they are non-shedding. So I think this is not addressed in this study. And also the negative one with the presence of hematopoietic of undetermined like origin, not addressed also, should be excluded by the techniques itself using the ctDNA. So what's your opinion, Dr. Shawki?
On which point?
Regarding this study, the false and negative results, did they address any comments about this one? False negative and false positive results of circulating DNA.
Well, it's not, I'm not sure if we can, the study did not, of course, address false positivity or false negativity because it's a technique that they used and they've made a criteria, what is the positive, what is the negative.
I mean, Dr. Shawki, excluding patients with non-shedding by assessing the preoperative circulating DNA. Did
Well,
they address this point?
They did not do that. What they
didn't.
did is actually they took the actual tissue, looked for 15 usually mutated genes, and looked for those mutations in the circulating tumor DNA. So they've used the actual tissue of the patient to see if there's any mutation. And the majority of the patient did have mutation in one of those 15 genes. Only 3 patients did not have mutation. So the number of patients who did not have mutation were small. And they've looked at even one mutation out of those 15. If it's there positive in the blood, then it is a positive.
All right, thank you. So next question is IO therapy with curative intent treatments in deficient MMR, local advanced rectal cancer, 100% CR, clinical CR. Is it changing the practice, single choice, agree, disagree, immature data? Can you please vote? I think as Dr. Ahmad Sheri pointed out, this study had a lot of publicity and a lot of debate in the community and also for the general population. I think is the most important part that because it's omitting surgery, but still we need. But we will see how is the attending look at the data as well. So 78% agreed that is a changing practice, even with all Dr. Ahmad Sheri and you, Gerald, pointed out it's not. And disagree about 8%, and people who was waiting for or thinking that it's still immature data, which is the most confident one, about 14%. So what do you think, Dr. Ahmad?
Yeah, I'm sorry to hear this and to see this number. I mean, because I mean, I think the effect of the media.
You try to be convincing.
Yeah. I think the effect of the media, as you know, and to be honest with you, I mean, this is really, really kind of promising kind of results. Yes. I mean, to have like a single treatment that basically does not cause major adverse events, and all patients, their cancer have disappeared, without need for chemotherapy, radiation, or surgery. This is hard to resist, to be honest with you. But if we look at, the small, very, very, very small number of patients, we are talking about 14 patients that have been reported. And the median duration of follow-up was in the range of 6.7 months. So we still consider these data are really, really immature to change our practice. We need to wait for longer follow-up, probably for bigger kind of results, or at least other studies that reconfirm the findings of this one. And as clearly mentioned by Professor Brager, it's feasible. However, it's experimental at this point of time. If I have a rectal cancer patient in my clinic as of today, a curable rectal cancer, I wouldn't offer him immunotherapy as a new adjuvant treatment. I would still consider concurrent chemoradiation, new adjuvant concurrent chemoradiation, represent the standard of care in that setting.
Even deficient MR patient, and they are a small population. And also we cannot anticipate one study to the other, like Keynote 177. We know this is a durable response for them, but I agree with you totally. Gerald, can you please comment on this as well?
I totally agree with Ahmed, what he was saying. It's experimental. I mean, what you can do is, and there might be certain cases, and you can do informed consenting with your patients on this experimental setting. So where you might go for that, but I would say it's not standard yet. It's very intriguing, but I would like to see, as Ahmed was saying, more follow-up data. And I think this is important. But however, for all MSI high mismatch repair deficient patient, keep in mind immunotherapy would have a place at the moment, for sure in stage 4, but neoadjuvant only on an individual treatment decision base, but not as a new standard yet.
So if you do have a patient coming to your clinic after all this data and after this all news coming with Twitter and all the people and then telling you, I don't want chemotherapy, I want this treatment, and he is refusing and he has the choice. So what you will do for him?
Yeah, if the patient is well informed consent what is the standard and the aim is cure and he wants to go for this experimental, it might be okay. But the first treatment choice for me would be, as Ahmed was saying, the standard of care with the aim of cure, and we have a high level of evidence. This would be my first choice. But if for any reason this is not possible or a patient is refusing to go for this and wants to have this experimental, you might go for it. But informed consenting is extremely important if you do something experimental.
Thank you so much. We'll go for third question. So the fourth question regards PADRM trial in RAS wild type patient metastatic colorectal cancer. Phase 3 study is significant study and establishing and confirming the upfront EGFR inhibitor in those patients. Yes, no, only left side metastatic patients. Can you please vote?
Okay.
So 75% yes, only left side it's only 15% and no for 10%. What do you think, Dr. Karan?
So in terms of the primary endpoints, it was met as per the investigators for the left-sided and the overall population, although the benefit in the overall population was less. I think the hazard ratio, if I recall correctly, was 0.84. They did present, interestingly, only the right-sided population, which there was preferential benefit of Avastin over the left-sided. Now, we have to take this, the result of this trial with the caveat that more than 3/4 of patients were actually left-sided. So did this drive or derive the benefit in the overall population? I think perhaps yes.
You never tried this regimen, Professor Brager, for a patient based on the site reduction of the depth of response, specifically that the higher response rate for EGFR inhibitor patients with RAS wild patients. So you are only confined to the left side. You never had it on the side reductive or rapid response.
Talking to me?
Yeah.
Yeah. So yeah, for me, it was a confirming study. So I would do for the left-sided RAS wild type, BRAF wild type, I would start with the anti-EGFR in first line for sure. So this has been shown in the CATGP 8045, in the FIRE3 study, now in the PADRM study. So yes, this is what it would be for me. It's confirming. It's nothing new, but it's confirming.
Okay. You never tried it on the rest side, on the side reductive or depth of response?
It depends. You know, the overall survival data are very inferior in many of these studies, and it was never tested for a clear neoadjuvant trial. So I'm a little bit hesitating on that. What is the aim? When do you need tumor shrinkage if overall survival was inferior? Okay, so you have to keep this in mind. So a clear metastatic, if there is probably, if it's an embedding threat or very high tumor burden, I need the quick response probably. But you have to keep in mind OS was inferior. So what do you do?
Agree, totally. So switching the gear to the sequence trial is sequential nab-paclitaxel gemcitabine followed by modified FOLFOX as an upfront therapy in metastatic pancreatic cancer, highly significant data. So do you agree? I have concern regarding toxicity. I may consider it in a resectable non-metastatic patient only. So can you please vote? So 69 agreed that it's a significant data. The people who have concern, astonishing only 19%, I may consider it as the higher response rate on this study. We can see only 12%. So Dr. Garni, can you have a comment?
Yes, I do. I don't think this study should change practice for many reasons. First, this is a phase 2 study. The second thing, in such population where the patient had already significant burden of the symptoms, adding such toxic therapy, I think as per the study, they didn't finish the analysis of the toxicity, especially neuropathy. So I don't think this is something that I would consider for my patient, especially in this study, they included super selected patient, 0 to 1, which we don't encounter very often in our population. So I still go with the current standard of care as of now. And the point that you raised about response rate actually didn't show more response rate. Actually, it's comparable to the FOLFIRINOX regimen. So still, I think it's experimental for me.
Dr. Prager, do you have a comment?
Yeah, as I was mentioning in the discussion, there was I think the control arm was not the right approach to go for, because you have 2 active agents compared to 4 active agents. So the design should be, if you go for nab-paclitaxel gemcitabine, within the study protocol, there should have been a second-line treatment options for those. I think, I don't know how to interpret those data, especially in respect that oxaliplatin had some conflicting data when it was given in the FOLFOX regimen. I think, so on Monday in office, I will not go for this regimen for my patients.
Even for if you can see that the response rate is high, so we may consider it for a patient who's resectable or potentially resectable? Or...
Yeah, but this was a metastatic patient population, so we
Yes,
don't know. If we do it borderline resectable, we have seen different trials with different data.
Totally agree. So last question regarding last study. So launch study, lenvatinib combined with TACE is the first study to show benefit of TKIs with TACE. And we had plenty of studies before, which was negative. And the main point that Do you agree, disagree, or abstain? Can you please vote? Do you think that the selection criteria for this study, it was not proper regarding that they have patient with PCLC, they should include patient with intermediate stage as a combination, Dr. Ashwa?
I think they should include patient also with PCLCB because these patients, eventually, some of them that are not a candidate for TACE, probably that will be the proper patient for the sequential therapy. So in terms of this combination, I think this combination, it's a trend to what's gonna be in terms of treatment of HCC. So I think we agree that lenvatinib is not the strongest medication treatment in HCC, and that's not the best standard in the first line, although it's one of the regimen in the first line therapy. But again, you know, there's some data about the ABC conversion using atezolizumab, and these patients converted for TACE, and they associated with a good response rate. I think it's the idea of having the combination of these treatment. We know most of us will be afraid about the toxicity, especially with Avastin and TACE, and that's probably one issue if we want to do combination or sequential therapy. But again, we have other immunotherapy that are available. So the whole idea of the combination, I think it is one of the best, because you would have patient with metastatic disease that respond outside the liver, and the liver will be the resistant part, which is make local regional therapy, it's important. And probably some synergistic effect between radiation and immunotherapy. There's too many combination, not only TACE as a local regional therapy and not only lenvatinib as a local therapy, but I agree as a concept is great. The only part of other combination in terms of toxicity, we know from sorafenib, too many trials, sorafenib and TACE, it was safe, but it did not show an improvement significant. But now we know lenvatinib is safe. Again, TKI probably safe with local regional therapy. We need to have more mature data about other mature regimen in terms of in combination with local regional therapy, not necessarily only TACE.
Thank you. I think the attending convinced with your opinion as well. We have about 82% agreed it's considered a signal. Even we do have now standard of care, which is atezolizumab, or the another study, which is the Himalaya, for the patient who did not, as it was pointed out, and disagree about 10%, abstain about 9%. So this is so last question regarding which abstract you find the practice changing. You can choose more than one. You have the dynamic, IO and rectal cancer sequence launch. Which one you will vote as a practice changing or the best abstract, and who is the winner? Can you please vote? I think the winner is the senior. So the winner is Dr. Shawqi as a dynamic study, followed by the IO and rectal cancer, 21 after you defending that it's not a practice changing, followed by the sequence, and again you defend not a practice changing, and launch as well. I would like to thank you very much for voting and for your comments as well. So if you do have any questions for the Dr. Professor Gerald or Dr. Shihri, it's the floor is open, and please go ahead. If you have any questions, or any one of the floor, they have any questions. So Dr. Ahmed Mustafa, do you have any question for the panel or the our professor? Well, it was amazing session. I would like to thank you all for attending this physical or virtual. I would like first to congratulate our eminent speaker for being here with us and their presentation and discussion as well. And last but not least, Prof. Gerald, we always happy to have you with us, and it was amazing session. Thank you so much, and have a great afternoon.
Thank you.
Okay. Can we have a group photo? Thank you.
شكرا دكتور محمد. شكرا دكتور شوقي.